test, test, test. عليكم. صباح الخير. We will start our second scientific day today, and our scientific program. The first session today will be an interactive session with the expert. So it's my pleasure today to introduce our expert for the first session, the second day, Dr. Mustafa Saad, a consultant of infectious disease and Arab Medical Center. Dr. Mustafa, well known, and he was a previous chairman of the previous AIDME. Welcome, Dr. Mustafa. The second, Dr. Ali Al-Barrak, consultant internal medicine and infectious disease in Prince Sultan Military Medical City. Welcome, Dr. Ali. Dr. Abdul Hakim Al-Thaqafi, consultant infectious disease in King Abdulaziz Medical City. Welcome, Dr. Abdul Hakim. And Dr. Tariq Al-Azraqi, head of internal medicine department at Asir Central Hospital. Welcome, Dr. Tariq. تفضل.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. It's nice to be here again with you, and I'd like to thank Dr. Muhammad Al-Abdullah, Dr. Zainab Al-Musa, the organizing committee, and everyone who has an input in this so far a very interesting meeting. Today we will start with an interactive case discussion, so please everyone is welcome to share with us. Now, when we reach to the questions, there will be a barcode, so please scan the barcode and vote. Voting will be live, and we need everyone to participate in this activity. So please take your cell phones and be ready. So with the help of our experts, inshallah, we will be, we will be discussing 3 interactive cases. So this is the first case. This is these are true cases. These are not fake, because I was asked yesterday about these cases. These cases are really true cases, and inshallah, they will be interesting cases. So the first case is a 55-year-old male patient, diabetic. This patient travels extensively, had malaria twice in the past, and that tells you something about his travel history. Last infection was in 2020, just before the pandemic. Presented to the emergency room with fever, chills, rigors, aches, myalgias, abdominal pain, diarrhea, and dysuria. His symptoms started while he was traveling, and he came directly from the airport admitted to the hospital seeking medical care. When the residents asked the patient about his travel, he told them he just went to South Africa. But actually, when we, ID part of our job is actually to dig into what is happening. So his travel itinerary was a bit more interesting. So his journey started in Amman. Then he went to Mecca by flight. Then to Egypt. Again, he was flying there. Then went to Sudan. From Sudan, he went to Ethiopia. This is all one trip. Then to Kenya. Then Uganda, then Rwanda, Burundi, Tanzania, and Bangladesh. The last place was in Bangladesh. So these are basically the countries that he visited during his travel. His travel lasted 40 days, so he was staying just a few days in every country. The patient received no malaria prophylaxis. He had yellow fever vaccine 7 years earlier, did not get any other vaccines for this travel. And he did not seek any pre-travel consultation, yet he's still planning to have some more trips similar to these ones. This patient is basically working with some Islamic charities, and they usually go and dig wells for the local communities. Sorry. What is happening? Can we go back to the slides? I'm sorry. The first question, when the patient was asked about malaria prophylaxis, he stated that he already had been infected with malaria. So he does not need any prophylaxis since he believes he is now immune. If he came to you for advice before travel, what would be your recommendation for his malaria prophylaxis? A, there is no long-lasting immunity about post-malaria infection. Reinfection can occur, therefore he should take malaria prophylaxis. B, there are several Plasmodium species. Infection can occur with other species, so he should take the prophylaxis. C, he is right, there is no need for malaria prophylaxis. D, he should get malaria vaccine. E, A, and B. Please vote. Okay, so let's go to our experts. Dr. Thaqafi will start with you since you are the first in line. So Dr. Thaqafi, what do you think in their answers?
بسم الله. طيب, I think this is a very busy man to start with, and he should be an expert really in pre-travel consultation. The service is available, widely available nowadays in our area. We have a lot of infectious disease, public health people, personnel carrying out these services in most of the institutions, especially in the kingdom. And this will indicate a lack of awareness of presence of such services. To cut it short, because we have 3 cases, first of all, let's tackle each distractor in these answers. Immunity usually, due to malaria, is not really very non-specific. It's species-specific. We have a lot of species of malaria. Usually, it's very rare to have a co-infection with malaria species. So each species infection can have an immunity that is short-lived, actually. In the literature, it's from 6 months, and some experts, they said it may last for 3 to 5 years. However, there is no cross-reaction or cross-immunity towards other species. So not taking prophylaxis before travel is not a very wise option for him. The other thing that definitely he needs a prophylaxis for malaria. Vaccines are not available yet, and still they are in the pipelines, but they are not commercially available or licensed for malaria species. So I would agree with the people who answered A and B, that he has to have prophylaxis all through his trip.
Thank you. So malaria prophylaxis, 2 vaccines has been approved recently, but these are for the use in children, not for the use. There is no recommendation so far to give any malaria prophylaxis pre-travel. There are 2 vaccines that have been recently approved in 21 and 23. The first one is for GSK, and the other one, I think this is the WHO vaccine. Again, both of these are just reserved for children living in high-risk areas. There is no recommendation so far to give vaccination pre-travel. So what would be the best option? So if we want to give this patient malaria prophylaxis, what would be the best malaria chemoprophylaxis option for this patient during his travel, knowing his travel itinerary, okay, just to cover all of the areas that he has been through? Please vote. Cast your vote. طيب. I think the voting is clear now. Dr. Azraqi, what do you think?
طبعا صباح الخير, good morning. So chemoprophylaxis, I will say it's very effective in traveler, and it should be offered to those who's going to endemic area. طيب, what option? We know Africa is chloroquine resistant. Let's, by exclusion, chloroquine should be out. We have Malarone, Miflequine, and Tavenoquine. One of these is acceptable. Malarone probably will be my first option. Miflequine given weekly, probably easier to take it weekly. Miflequine, the problem is it can cause CNS, probably it can cause nightmare. It's known. Especially if you are going for a trip, you want to enjoy yourself and you take miflequine and then you start to have nightmare during your vacation. It's people, they don't like miflequine as a prophylaxis. Tavenicone also can be. So I will exclude chloroquine.
Okay, excellent. So anyone?
Dr. Saad, I will be the opponent for Dr. Miller. مشكلته إنه you will be taking it on daily basis, so it would not be probably, compliance issues. This man is religious. He's going for charity and these things, so I will try with him miflequine.
Okay.
I will try with miflequine because of the weekly compliance. The problem that he is now going from Africa areas to the Indian subcontinent. So there will be two different resistant patterns in those areas. But I would start with miflequine. The problem with miflequine is that when I want to give him quinine later on, if he had malaria, it would be a challenging that I would not need to give a loading dose for him. So for me, I will counsel him and tell him about miflequine.
Dr. Thaqafi, do you have any other answer?
All of them are working except for chloroquine. The miflequine, I have a concern that for military personnel in a missionary or a pilot, it's not really recommended because of the CNS effect, and businessmen as well. It may affect their decision sometimes in their negotiation, especially in a short lift trip or so.
A question to the audience. Where miflequine would not be expected to be effective, which countries we have they have reported resistance specific to miflequine? Anyone in the attendees? طيب. Experts. طيب, Doctor, anyone who wants to help us with this? طيب, miflequine resistance has been reported in Thailand. And just to know, this patient did not go to Thailand, but if he was to go to Thailand, like if his trip was involving Thailand as well, and Cambodia, those two countries, miflequine resistance have been reported, so this is not a good medicine in those two countries. Tafenoquine is a new molecule that has been recently approved, similar to primaquine, and it seems to be effective in all of these countries. So the answer would be all of them except chloroquine. Chloroquine still effective in some areas in South America and Central America, but not in the rest of the world. Now, if this patient came to you and he wanted to take vaccine, but he didn't, unfortunately, and you have the opportunity to give him the vaccines, what of these vaccines you would offer to this patient? A, yellow fever vaccine. B, rabies vaccine. C, hepatitis A vaccine. D, typhoid vaccine. E, Japanese encephalitis. F, all of the above. Finally, G, none of the above. Okay, it seems we have some answers. Dr. Thaqafi. Dr. Ali.
طيب بالنسبة لليلو fever, he had already yellow fever 7 years ago. So by the old rules, إنه خلال within 10 years you had the vaccine. You don't need to have the revaccination. Recently, because of the shortage of the vaccine, they say that one time in a life. So he took the yellow fever vaccine. For rabies vaccine, it all depends on the activity that he's doing. If he is handling animals or he's going into the forest, if he is يعني صياد يصيد wild animals, it would be a risk for bite and these things. So rabies, yes, if he is indulging in these kind of activities. Typhoid vaccine, he's 55, he's diabetic patient. So if it is available, yes. If it is not available, I mean, he just take the precaution. What I could see from the areas that he's gone around, he would be probably exposed to local food, local water, running water. So it would be a risk. It's the same thing for hepatitis A vaccine, which is also waterborne disease. What else? Japanese encephalitis is just because of Bangladesh and the areas there, and if it is the season. But usually it is been seasonal, and it depends on what time of the season. But I will also add on top of these vaccines, travel vaccines, is his checking up his adult vaccination coverage, i.e. this is an opportunity to boost his immunity with certain vaccines. We had, I mean, for him, he's 55, he's diabetic. Influenza vaccine would be another one. A pneumococcal vaccine would be a second one. I will check for his hepatitis and others. So I would take this opportunity to check his vaccines need.
Thank you, Dr. Ali.
And also tetanus.
Yes. Okay.
What do you think of dengue, Dr. Barak? If it's licensed vaccine, there are 2 licensed vaccines now in South America, in Brazil in particular. Bangladesh is a heavily dengue area. So this guy will have a lot of busy itinerary according to his interest. So I would recommend all these vaccines except if he's already vaccinated for the yellow fever. Japanese encephalitis, we were debating, Dr. Azraqi and myself, that the vector is there in Africa and in Bangladesh, and the virus flaviviridis is abundant in there. So yes, advisable. ويمكن نروح اليابان نسوي دعوة.
His travel involved visiting many remote villages, eating local food, including salads, and recalls having many insect bites. He was always checking insect bites. He was drinking mostly bottled water, so he was careful with this. Does not recall removing any ticks from his skin and did not swim in freshwater lakes. He is heavily involved in digging wells. They go there and they dig wells for local communities for drinking water. And he reported no contact with wild animals. And lastly, his trip lasted for 40 days. Which of the following pathogens is acquired from direct contact with contaminated fresh water? A. Naegleria fowleri, B. Cryptosporidium parvum, C. Schistosoma mansoni, D. All of the above, E. None of the above.
Skin disease?
Okay. Dr. Al-Azraqi, what do you think? Dr. Thaqafi, sorry.
Actually, all of them, they are يعني, a risk to be acquired through water contact, especially Cryptosporidium and the Schistosoma mansoni. Schistosoma is still really prevalent in some part of his itinerary map, actually. And I would say all of them.
Okay. Well, all of them are waterborne, so all of these can be expected if this patient is dealing a lot with fresh water. Which of the countries he visited during his travel has reported cases of Ebola virus disease outbreaks? A, Ethiopia, B, Kenya, C, Uganda, D, Rwanda, E, Burundi.
اوغندا بس اوغندا بس الاستاذ بس لا هي كلها نيبرين كنتري بس ما هي ريبورتد يس
دكتور الأزرقي دكتور طارق.
Well, I have to look into the map and see. Anyway, I think there are Uganda definitely, and also Congo. Congo, I know that recently they had a big outbreak. And the outbreak of Ebola, it's from time to time. I mean, you know, I think every 5-6 years we have an outbreak. In fact, I know Uganda and Congo. Ethiopia, I don't think they had any outbreak there. Rwanda also, I don't think they have. Kenya. So Uganda definitely, and Congo.
So this is the map. So this is the most recent from the CDC. Those are the countries that have reported Ebola virus outbreaks. So Uganda was one of the countries that he visited. Congo, this is a table basically showing the outbreaks since 2014. So in the last 10 years, as you see, Uganda had it lastly in 22, but the Congo, the Democratic Republic of Congo, has been reporting a lot of cases. And I think we remember in 2014 when we had the large outbreak in western countries of Africa, Guinea, Sierra Leone, and Liberia. That was actually the biggest outbreak that we had so far, and they had a lot of patients who died in this outbreak.
The problem with the hemorrhagic fever is sometimes that it's not being reported by the national countries. So it would be wise also to ask the patient himself if he has seen cases of hemorrhagic fever, somebody who had fever and these things, because it would help to know exactly what is in the local area that he visited. He's visiting villages, but he's not been going into the wild. He's not being exposed to monkeys and other wild animals.
Thank you. So this patient, his initial investigations, the white count was 9.6, mostly segmented cells, platelets more than 200, the hemoglobin 14, the chemistry was normal, except for AST, ALT were also normal. CRP was 179, and his chest X-ray was normal. He had multiple malaria smears that were negative. Blood film did not show anything. Blood cultures were unremarkable. Urine analysis was unremarkable. Urine culture was no growth. He was reporting dysuria. His stool analysis showed 4 to 6 white cells. Entamoeba, histolytica cysts, and the trophozoites were isolated, and the stool antigen was done to confirm the result. Stool culture did not grow anything. His stool C. difficile toxin was negative. So given this patient's analysis, which is basically Entamoeba, histolytica cysts, and the trophozoites, what is the best antimicrobial regimen to give to this patient? A, metronidazole, B, diloxanide furoate, C, paromomycin, D, metronidazole plus either diloxanide furoate or paromomycin. So excellent. So our attendees know the answer this time. So what do you think?
Since the patient has the trophozoite of Entamoeba histolytica, so he probably had an active infection, and because if he has symptoms, I would probably treat him. The problems with these medication is the availability of them. I mean, we would like to have some, all of them to treat, but usually I would go with D, which is metronidazole plus either whichever available of these the other medication. Also, for somebody who had GI infestation of parasite, I would take them as a package. I mean, GI contaminated food, meaning that the patient has been exposed to so many. What we could see is the trophozoite and the cyst at this time. Probably would see something else when we do. So it would be wise to treat him as a package for this parasite. And follow up his symptoms later on. I would be also worried about the compliance of the medication. I mean, to make sure that he's taking the full course of the medication.
Thank you. So his fever resolved within 24 hours of
I add
admission.
just one point.
Oh, yeah.
In non-endemic malaria area or in a center which they are not really get used to examine malaria in the smear, يعني outside of Jazan and Asir area in Jeddah, so I would recommend to repeat the malaria film 3 times at least, thick or thin, even film.
Yes.
And you need an expert really to read it, or you use the antigen, of course.
Yes.
And the presentation, you cannot say it is not malaria. Malaria
yes.
can present the same thing.
Yeah, sure.
But أعتقد إنه عندنا هنا we are doing first the antigen capture. This is the first step. You don't do smear. Because it's more sensitive. If it's positive, then you go the smear.
It's not available.
Huh?
It's not available everywhere.
It's not available. بس أنا وأنت يا محمد اللي عندنا.
Outside Jazan and Asir.
It's not always available. The test is not. Well, we can ask the audience who has malaria antigen tests in his lab.
مين اللي ما عنده أيوة.
So not everyone. Okay.
Antigen capture is not available in other hospital اللي هو antigen detection for malaria.
Well, not everywhere.
One case a year it comes, so the lab they will not make the vision.
So his fever resolved within 24 hours and showed a quick clinical improvement. This patient was started on admission on ceftriaxone and metronidazole because of the impression was this is some kind of gastroenteritis. Follow-up investigations on day 3, the white count was stable, platelets were above 200, actually went up to 247, his hemoglobin was stable, CRP went down to 45. The patient was allowed to be discharged, but he insisted he will never come back to the clinic to seek any more advice. And he's traveling soon in the coming future. So sometimes we get these patients, and he did not show up. And he was truthful. So case number 2, we will shift gears now to talk about something different. This is an 85-year-old female patient with hypertension. She had COVID-19 infection in February 2023, so recent, and it seems it was complicated by the development of lung fibrosis. She presented in September of 23, so around 8 months later, with a chronic cough, productive of copious amounts of yellowish-greenish phlegm. She also reported having chest tightness, progressive exertional shortness of breath, and generalized weakness. Had poor appetite. She had felt a lot of chills. She was feeling always chilly, but never had any documented fever. And it seems she had some weight loss, but again, it was not documented. Did not have any night sweats, and did not have any other systemic complaints. She had a CT scan done in September, and she was seen by a pulmonologist who saw some cavitations that were faint. He decided to treat her empirically for some kind of chest infection, but the treatment was not successful, and the patient continued to have the symptoms and presented again in December 2023 to another pulmonologist. This time, the pulmonologist decided to admit her, and she was admitted on January 2nd, and to have some further workup. On examination, she's an old, weak, and frail lady. She's afebrile at the time when she was admitted, and the rest of the vital signs were stable. She was having some bilateral rhonchi, but it was more pronounced on the left side. Did not have any other findings on the physical examination. Her lab investigations were mostly unremarkable except for some elevation of the GGT. Albumin was a bit low, LDH was 189, CRP was 74, and ESR was 67. This is her chest X-ray. So do we have a pointer? So you can see there are some fake, the arrows indicate some faint, what looks like a cavitation here in the chest X-ray, but if you look at the chest X-ray as a whole, it looks like really a lady with some fibrotic changes in both lungs. So it's more like a fibronodular disease. And this is the chest CT scan. This is just to show you the extent of the cavitations that the patient had. And some of these are really thick-walled cavitations, so they're not really faint cavitations. So you can see here, this is at one level, this is another level, and this is a third level. So this patient had multiple cavitary lesions, and it seems she's still having active infection. And you can see even the consolidation that the patient has. So she has something ongoing. Now, you are called by the admitting physician for advice regarding patient's placement. Which of the following statements is the best recommendations for admission? Admit to a private room under droplet and contact precautions. B, admit to a private room under contact precautions only. C, admit in a negative pressure isolation room under airborne room. Well, where is the D? Admit in a negative airborne isolation room, and all healthcare workers should wear an N95 mask. And E, admit to a private room under a droplet and airborne precautions. Please vote. So our experts, Dr. Tariq.
Okay, so this patient highly suspected of pulmonary tuberculosis. She has the symptoms. She has high biomarkers, inflammatory biomarkers, and she also has a cavitary lesion in the X-ray. So we have to consider pulmonary TB, which is highly infectious. It's an airborne disease. So I think I agree with the audience about the we have to put an airborne isolation, negative pressure room, and specify the healthcare worker should wear N95 respirator.
Okay. So this patient was admitted, and she underwent bronchoscopy with a bronchoalveolar lavage, and the BAL was sent for all kind of microbiology and cytology, and soon the lab called with a positive AFB smear on the BAL, 3+. The TB PCR on BAL was negative. Given the results of the BAL, what does the patient have? A, pulmonary TB. B, mycobacterial infection, probably TB, but NTM, non-tuberculous mycobacteria, can't be ruled out. C, non-tuberculous mycobacteria lung infection. And D, the data is not enough to make a presumptive diagnosis. اللي حضروا الأمس المفروض يعرف يجاوبوا اليوم. دكتور علي.
Common in our areas is pulmonary TB. But she's a frail lady. She has been treated for COVID with pulmonary fibrosis, so she probably had a lot of steroid. She has a lung destruction pathology, so she could be at risk for non-tuberculous mycobacterium. But in our areas, I always say do not trust the PCR. It might have false negative. And for the public health, precaution, I would say pulmonary TB, pulmonary TB, pulmonary TB, then others. I would not be settling down with just only having negative PCR.
Yes. Now, probably it's good to explain to the families that this is likely TB, but we cannot prove it. This is not a proven 100% TB, so there might be a chance for something other than TB. But the working diagnosis and the treatment should be targeting basically nowadays, at this time, it should be targeting TB. So this patient should be started on anti-TB therapy, and if the panel wants to comment on this, Dr. Azraqi, Dr. Thaqafi.
Yes, I agree with Dr. Ali. TB is a high possibility here. Non-tuberculous mycobacterium, it should be also in your differential, especially you have negative PCR and you have positive AFB smear. But as mentioned by Dr. Ali, you could have false negative PCR. Probably it need to be repeated, but it also should be in your mind. Yeah.
I don't know if this lady was on a steroid or not for her lung fibrosis. This is very good because if she's a long-term steroid, there is really a very, very minor possibility that you have to put nocardia in your mind with such a lung X-ray.
Yes. So I think this is a very important point to make. Patients who have a positive AFB smear and having cavitary lung lesions should be treated as TB, regardless of what the future would show. Okay, so initial management should be as such. And this patient was offered a 4-drug anti-TB regimen, the standard basically. And unfortunately, that happens with a lot of patients. They cannot handle the therapy. So she was having severe nausea, but fortunately she was not vomiting, but she was unable to eat, and she had to be supported with IV fluids and other supportive care. Fortunately, her liver enzymes continued to be normal. Now, when this patient can be safely discharged home? Once clinically stable, so this patient is already on therapy for 1 week now. Once clinically stable and can be home isolated, B, should be kept under isolation until we get 3 negative AFB smears over 3 consecutive days. C, when TB cultures become negative. D, when the cavitary lesions resolve. E, no need for isolation. Dr. Thaqafi.
You play it safe, actually. This is the recommendation that you have to isolate patient till they are AFB smear negative. However, it's really very difficult to keep all these patients under isolation. So we have, and we don't have a confirmation of TB. You have to put this in mind. Usually the AFB, even in a pulmonary TB person, can last positive in very rare cases to 120 days. But once the patient is able to take orally, well supported, and his clinical presentation signs and symptom improves, and he would be able to support himself alone, we can discharge them in a home isolation as well till we have a confirmation. So you don't need to keep them till their AFB is negative.
Any other comments?
AFB smear.
Yeah, AFB smear. I mean, if we go to the MOH guideline, it's the first one, which is 3 consecutive smear negative AFB. But if you have constraint of rooms and you have a good preventive medicine that they can follow the patient, and the patient is well educated, he will listen to you, he will stay at home. I think other option you have, once the patient is stable, you can do a home isolation. So depending on your situation. If you have luxury of rooms, you can keep the patient. If not, then you go to the second.
I'm not sure if anyone has the luxury of rooms these days. And it's actually more difficult if you are in the private. So in the private sector, it's very difficult to keep patients. Remember, these patients, someone has to pay for these patients. So it's a challenging situation. Dr. Ali.
The patient is a frail old lady. She would need to be with her families. They will encourage her to eat to get well quickly. So we have to take that into account. On the other hand, also, she's been sick since September, and now it is December, and she is being exposing everybody in that area, in her home to this. But this is not an excuse to discharge her if she, I mean, if there is a high risk population inside the house, especially children less than 6 years of age, especially if there is an immune compromised at home. I would probably keep her a while until she's smear negative, or I have an alternative diagnosis.
Okay. Any other comments from attendees? I think this is a very important aspect of management, and we face it a lot with our patients. I think it should be individualized, but some of the international guidelines now, they're trying to push the patients earlier for home isolation, but again, we have to make sure the patient is being isolated at home. Do we need to screen the household contacts for TB? They have been exposed since September at least, or even before, because this patient has been having symptoms for a long time. Screen or no screen, or not sure? Dr. Ali. Oh, doctor.
I would not screen at this time since she is smear positive, but PCR negative, and I still have other differential diagnosis. On the other hand, I would like to have a baseline for the family. That would help in the management later on. Somebody who's been diagnosed to have TB today, I would prefer to delay his screening later after 4 to 6 weeks after the exposure to make sure. But giving this patient that she's been at home since September till December, probably she has already been exposing whoever. So I would just hold on for a couple to 4 weeks, 2 weeks to 4 weeks before doing the screening.
But you can do, I think you can do screening now, and for those who are negative, screen after a month. This is what we will do.
Yes.
I mean, screen initially, if negative, you rescreen those negative after 1 month.
So we need to have mostly screening twice, one at a baseline just to see their baseline status, and then to see who's converting. Basically, that's what we do. So all of the family members were screened by IGRA and all tested negative at baseline. The patient was discharged home within 1 week. She has the setup to be discharged home. After 2 weeks of therapy, the sputum samples were repeated ×3 and they were negative. Bowel culture results, now they're coming, for bacteria, fungi, and nocardia were all negative. TB culture was reported to be positive on Magid, so the liquid media was positive after 22 days, and it did not grow TB. So TB was not detected, but there was non-tuberculous mycobacteria growing there. How would you treat based on the culture results? Now, this is the second challenge. Hold the therapy until full identification and susceptibility become available. B, change regimen and include agents with known activity against common non-tuberculous mycobacteria. C, continue the same anti-TB regimen since her sputum AFB turned negative. D, keep anti-TB regimen and give 2 additional drugs that target non-tuberculous mycobacteria. E, no need to treat since this is not TB. Vote. Okay, Dr. Thaqafi.
So this is definitely a slow grower. So that's give us a peace of mind at least. To me, I don't shoot in the dark, really. The fact that she's responding, most likely there is some agent in her combination therapy are working. We know that a universal NMT, rifampin, and ethambutol are working sometimes, most of the slow grower. However, I would wait for the sensitivity till it comes to give really a narrow option. Otherwise, if we don't have this available, definitely I will give a third agent like clarithromycin or or azithromycin macrolide, plus minus injectable aminoglycoside. But I would rather wait till I have a sensitivity.
Well, I think I will change. I think I will go with I will change. Now it's clear. It's in NTB. It's been reported by culture. So we know that PZA and INH is useless. So I will stop this and I will add macrolides to the regimen along with rifampicin and ethambutol.
I would agree with Dr. Tariq. Given that, hepatotoxic medication like pyrazinamide and INH is not indicated in this because she has no TB, I would probably keep the others and continue since she had some kind of improvement.
Well, pyrazinamide and isoniazid are not really very helpful with the non-tuberculous mycobacteria. So in this case, they will be just adding to the toxicity. And this patient is not really capable of handling the toxicities with these medications. So probably stopping these would be a good thing to do. Rifampicin and ethambutol, although the activity is not really clear, but this patient had some responses. The sputum AFB smears on 3 days, different days, tend to be negative. So the patient has something that is really effective for her non-tuberculous mycobacteria. And basically, a macrolide-based addition probably will be a good thing to do at this time. Now, would we leave her without therapy until we get the final culture results and susceptibility? I personally, within this patient, was really sick. So she had symptoms, she had a bad lung disease. So probably, Anna, I was keen to treat this patient. So moxifloxacin and azithromycin were added. And the patient's symptoms, after 4 weeks of this regimen, the patient's symptoms improved significantly. Now she's able to eat, her lethargy decreased, her weakness improved, and the expectoration decreased a lot. She's not now coughing a lot, and she does not have much sputum production, and her activity has started to improve. Shortness of breath improved. Chills as well resolved, and she did not have any new symptoms. The culture was sent to Biosynthia for final identification, and the final culture grew Mycobacterium simi, and again the susceptibility is still pending. So as of today, we don't know the final susceptibility result for this patient. So any comments from the attendees or our experts?
Dr. Mustafa, and I noticed in my clinic, we have increasing incidence of NTM. We call it MOT or NTM. I'm following now in my clinic 5 patients. And it's like this patient who has a destructive lung disease, structural lung disease with pre-existing cavity, and they come with typical presentation as pulmonary TB, and it turned to be MOT. It seems that, I don't know, is it increasing or because we are more able to detect it? And this is probably, it's been probably diagnosed before as pulmonary TB, Mycobacterium TB, but in fact now because we have more facility to detect MOT, we noticed that there have been increased number, and I have seen it in like I'm following 5 patients in my clinic with MOT.
Well, that's a good note. Dr. Thaqafi, if you have any comments. Dr. Ali.
The thing is that about our population now is aging. There is a lot of what we call it COPD and lung destruction that happen after certain infection or certain exposure to inhalation. Plus, our labs are becoming more agile to get the diagnosis and sophistication. So I would probably take into this consideration when I'm seeing patients who have lung destruction, being on what do you call it, an immunosuppression for a long time, I will be very, very cautious when I see these kind of patients suspected of quote unquote AFB positive things. I would still put TB up in, higher in the differential diagnosis, but I will be open-minded to the NTM.
Okay, just a couple of slides about the Mycobacterium simi. As you can see here, our areas are actually endemic with this Mycobacterium. It seems to be available, it's present in this area and the kingdom here, the Middle East. We have a lot of cases reported from the Middle East. And it seems this Mycobacterium likes this area for some reason. So it's available, it's present here, and it's our duty to find it. So probably if we look more, we will find more of these cases. The rates of infection meeting the ATS diagnostic criteria has been widely reported in the literature, from 21% to 100% in one report. And resistance to all first-line anti-TB therapy is common among this Mycobacterium. This Mycobacterium has been reported to present with disseminated infections, with positive even blood cultures, and refractory bacteremias with osteomyelitis and multi-organ dysfunction. Just a reminder, this is the ATS diagnostic criteria, so we have to have clinical criteria where we have symptoms and some findings on the chest CT scan or chest X-ray. Besides appropriate exclusion of the other diagnoses, so this is the first clinical criteria. Then we have to have some microbiological criteria, either sputum cultures positive on more than one occasion or one positive bowel. So both of these can give us a presumptive diagnosis, but the definitive diagnosis requires a histopathological diagnosis with either having a positive histopathology or mycobacterial culture from the pathology growing the Mycobacterium simi. The treatment, there is no randomized controlled trials for treatment in Mycobacterium simi, no standard therapy, and it's one of the difficult, slowly growing mycobacteria to treat. So it's not an easy one, but if you review the literature, it seems macrolides seem to be the most effective. Then some of the quinolones, mostly moxifloxacin, rifabutin, and clofazimine seem to be effective in many isolates, but not a lot, and then aminoglycosides. Ethambutol had some activity, varying activity in different reports, and rifampicin does not seem to be very good, but it's not universally resistant. And finally, the INH and PZA, they're almost 100% resistant, so they're not of use. And therapy should be guided by drug susceptibility in all of these cases. And here you should send it, really, if you cannot do it, you have to send it to a referral lab. Unfortunately, I think we're running out of time, and I think we have to stop here. Thank you for attending with us this morning. Thank you to our panelists, and we'll move on, inshallah, to next session. Thank you.
Thank you for our expert. It was interactive and we learned a lot. So we'll ask Dr. Zainab for recognition of our expert for the interactive session. تفضلي دكتورة. دكتور مصطفى سعد تفضل. دكتور عبد الحكيم الثقفي. دكتور علي دكتور علي البراك الله يعطيك العافية دكتور. Listen. We will move now for the second session of our day. It's about tropical disease in pediatric. So I want to ask Dr. Zainab Al-Musa and Dr. Ghail Al-Granis for moderating the next session.
في مايك ولا خلاص؟ ايوه بس في مايك. Assalamu alaikum. Good morning, everyone. We really enjoyed the previous session. I hope you enjoy our session. I am Dr. Ghail Granis, Pediatric Infectious Disease in Prince Mohammed bin Abdulaziz Hospital in Medina. Me and Dr. Zainab Al-Musa, Pediatric Infectious Disease in Al-Musa Specialist Hospital, will moderate the session 5 about contemporary issues in tropical infection in pediatric patient. We have today a fabulous speakers. It is my pleasure to present Dr. Isam Banyan. He is a chairman of pediatric department at King Faisal Specialist Hospital and Research Center in Riyadh. Dr. Isam, he got his MBBS from King Saud University College of Medicine in Riyadh, Saudi Arabia, followed by American Board of Pediatric and American Board of Pediatric Infectious Disease. Dr. Isam has numerous publications to his credit, and he is affiliated with several prestigious medical organizations, including the American Academy of Pediatrics, the American Medical Association, the European Society of the Clinical Microbiology and Infectious Disease, and the Saudi Pediatric Infectious Disease Society. Today we'll give us a talk about the Brucella new management guidelines of the Saudi Pediatric Infectious Disease Society. Welcome, Dr. Isam, and the floor is yours.
Thank you very much. يعطيكم العافية. بسم الله الرحمن الرحيم. السلام عليكم جميعا. I'd like to thank Al-Musa Specialist Hospital for inviting me. It's always a pleasure to be in the beautiful Al-Ahsa and in this great conference they have every year. We hope to do it again next year, inshallah. I'm going to speak about Brucella, and I think the focus is going to be on pediatrics and some of these special aspects of Brucella that impact pediatrics directly or indirectly. I think Dr. Mimish, if you attended yesterday, covered many of the aspects I may be talking about today. But in the concept of education, I call this a term called layering, where we helpfully improve your knowledge of a topic by adding layers to it. So you might see some things that are duplicated, but hopefully will add to your knowledge maybe from a different angle. I think the question is brucellosis rare in Saudi Arabia? And unfortunately, technically brucellosis is a rare disease, if you will, around the world. But unfortunately, in Saudi, technically we wouldn't call it rare. It's actually endemic, and we're considered one of the endemic regions of the world. And considering our socioeconomic status and so on, you'd hope that we would be more like countries in North America or in Europe or Australia, where brucellosis is rare. And by the way, I congratulate you, Dr. Zainab, on having this conference. If you know, February 29 was Rare Disease, International Rare Disease Day, so I think the conference theme goes very well with that. But coming back to this, Brucella is actually relatively common. If you work in the National Guard where I used to work, we see cases a few cases a month in pediatrics, and Dr. Mimish and his team saw many of those. And this is a problem. And the reason is that many, multifactorial, but cultural is probably one of the biggest reasons. And I think many of you here, Al-Ahsa is a region that has many cattle and herd and domestic animals. Culturally, it's very challenging here in Saudi Arabia to take some of the measures to control brucellosis that you would see in North America. Some of the challenges are the strong belief, and in the National Guard it was very difficult to change people's minds that drinking raw milk was actually a healthy thing, and it's something that's considered very good for them. Very difficult to sway that idea. The idea, a part of one of the core tenets of control is actually detection and slaughter of the animals that are infected. Again, very difficult. I've noticed some of our National Guard population, they were more attached to their animals sometimes than their children. And we noticed this, and it was something very interesting to see. But that's part of the culture. in addition to all the costs and so on. So it's a very difficult disease to control if these measures are not taken. And you can see here it's actually marketed. You find this on the website. This, I think, is a tourist actually coming to visit Saudi Arabia. You'd hope she'd take away some good memories, not brucellosis, back to her country. But it's a problem. The organism, I won't dwell on too much. You heard from Dr. Mimish yesterday. I think the most important fact is that Brucella melitensis is what's most prevalent here in Saudi. And that's the problem because it is more virulent. And this is just a classic picture from our red book, the classic gram-negative coccobacilli that you'd see in the lab. And this is a problem. We'll come to that in a minute. And Dr. Mimish touched upon it. It's a reportable disease, which is good. So this is one of the diseases where your lab has to report. So we do have fairly good data on the number of brucellosis. But when I mentioned earlier, is it endemic? In 2021, if you go to the Ministry of Health's website, unfortunately the slide did not reach on time to the team here. That was my fault. But they had 2,400 reported cases in 2021. In 2022, they had 2,600 cases. So it's not like we're making ground. And I know Dr. Mimish showed you the vaccine slide, and I'll come to that in a minute. The problem is that it's not only an impact on health of the population, even children, and it's very challenging in children, as I'll come to in a minute, but it also has a huge economic burden. On herders and the economic burden on countries, on productivity, countries that rely, or areas that rely, like Al-Ahsa or other regions, that rely on domestic cattle for their income. However, again, it's very difficult to convince a herder thinking long term that we need to slaughter part of your herd or even vaccinate. And I'll come to the issue of vaccination of the herd. But the losses are huge with brucellosis in countries. Sometimes some of these countries are actually poor countries, considered poor countries. And I'm sure Saudi Arabia has similar losses, although we don't have data on that. The clinical presentation in children is a bit more unique than adults. It's almost always acute. We rarely see these chronic indolent presentations in children. Usually within a week or two, they're presenting to us. It can be vague, and you have to have a high index of suspicion. Any organ can be involved, but more commonly it's monoarthritic, and often we get referrals that this is septic arthritis and patients being worked up for septic arthritis if the index of suspicion for brucellosis is not high. And we don't see, as in adults, the sacroiliac joint or osteomyelitis. It's rare in children. One of the more challenging presentations, and I would say not uncommon, we in the National Guard, we'd have two or three a year of neurobrucellosis. And they have, I think, a series that was published from one of our colleagues from the National Guard. I've been at King Faisal for about 5 years, and King Faisal is more specialized in referral, but we've had 2 cases of neurobrucellosis in the last 5 years at King Faisal, which is still high, but it can be very challenging, very difficult to treat. This is an example of one of our children, about a 4-year-old child, who came to us with a actually not too long course of fever, seizures, and I think the team was smart enough to look for brucellosis, and it was positive both from the blood and then the CNS samples. And this child was very difficult to control the seizures initially. There was a debate about surgery and so on. It was a very challenging case. And he's now been on treatment for almost 2 years now. He's better and doing well, but in the first few months was a very difficult case to manage. And a lot of antibiotics, we'll come to that. The standard classic diagnosis, or the gold standard, is of course the blood culture from any sterile fluid, or the SAT test. I'll come to those in a minute. And again, Dr. Mimish touched upon that. But there's a few unique things that I'd like to layer or highlight, especially for the frontline clinicians, those who work in the primary practice, who may see these cases and actually can manage these, I think, very well. The culture is the gold standard. However, the yield is suboptimal. It can be, if you catch it early, if you have a high index of suspicion in the first week or two of the disease, it can be a good chance you'll get it, isolated. But if it's been longer than 2 or 3 weeks, the yield is very low. And now with the new systems, you don't have to tell your lab if they have these new systems, and most labs have these new systems. You don't have to put it in for 4 weeks or the classic prolonged culture. And this is, when I come back to the organism, the challenge with culture, that Brucella is considered a class 3 organism requiring class 2 or step 2 lab measures. And can be challenging for many labs. And so again, while culture is important and you can get the susceptibility testing, Dr. Mimish touched upon some of the challenges we have with this, but I wanted to highlight something that maybe Dr. Mimish didn't touch upon, was the discrepancy between the in vitro susceptibility and in vivo outcomes. It's interesting that we've often, at least in children, have, for example, isolates that might be resistant to rifampicin, for example, reported. But we still use it as a first line with good results. And I know that doesn't make sense, although we try to follow the susceptibility data, but in some young children, the choices of antimicrobials may be limited. And so remember this sometimes, and if you're talking to the infectious disease consultant, we might actually go with a combination that may not go with the susceptibility. The serological tests, the gold standards are the SAT and the ELISA. This is the SAT. And I'll highlight again a few caveats or important points about the SAT. Dr. Mensch touched upon them. It measures the anti-LPS antibody from brucellosis. And this test measures, it's a basket, the IgG and IgM together. The IgM against LPS is not very reliable. It's actually not very specific. It can be positive in many disorders. So that we're actually looking for IgG. We don't like the IgM and the SAT. So it's helpful for the acute diagnosis. For follow-up, it can persist for a very long time, especially those IgM antibodies. And so, as mentioned yesterday, keeping an eye, looking for the titer to normalize is very unlikely. You can have actually up to titers of 1 to 320 a year well into the disease. And this is very interesting. Almost 3% of the Saudi population had titers of 1 to 160, 1 to 320. Now keep in mind, this was a study done in the National Guard, so it might be biased. But again, it can be tricky just to use the SAT for follow-up, but it's excellent for the acute diagnosis. So this is, I think, just a summary of what I mentioned just now. The screening purposes, sometimes you do have to screen. If you're screening family members in an endemic area, because of the data I just showed you, we don't use 1 to 160 as a cutoff. That would probably include patients who do not have disease, but simply have high titers. And these are not patients who have chronic disease. Someone asked the question yesterday about chronic disease. These are not patients who are infected. They just have persistent titers. This is another method some of the labs use, and if you do have this technique, it can be very helpful. This actually is a technique that gets rid of the IgM that we talked about and only follows the IgG and can add much more to the specificity and the response to treatment if it's coming down quickly. Because again, the IgM in the SAT can be unreliable. The ELISA actually is better. I'll use that term very general. It's better in the sense that it's actually specific. It's looking at cytoplasmic protein as the antigen. So the IgM and IgG are very specific and very helpful. However, it's not well standardized, much more expensive, as Dr. Memes showed yesterday. The sensitivity and specificity actually is, if the SAT is done well, is actually comparable to SAT. Therefore, the SAT for the acute diagnosis remains the gold standard. And if you have it, it's a great test. But the ELISA may be great for follow-up or for if you suspect relapse or reinfection. And for CNS disease, the ELISA is the test of choice. And you should have that done if you suspect CNS disease with brucellosis. PCR, I won't dwell on it. Unfortunately, it's available. You'll see some publications. Has not been standardized, has not been widely used yet. And again, many of this is because it's challenging to develop a standardized, easy PCR to do. And a lot of it is related to funding also. I mentioned that if there was a worldwide pandemic of brucellosis, you'd have a PCR test, a vaccine, an animal vaccine within a few weeks. I think it can be done, but I think a lot of work still remains till we have a standardized, easy commercial sort of point of care testing for brucellosis. These are some of the tests that if you're a frontline physician, you're suspecting brucellosis, you'd want to get these tests. The basic CBC, the ESR. Interesting, the ESR compared to, for example, septic arthritis or osteomyelitis is usually modest elevation. We don't see these high 100 plus or high CRP in brucellosis. And it can give you a hint this might be brucellosis. Liver function test. Again, it's tricky because you usually get some moderate elevation, maybe 2, maximum 3 times elevation of the transaminases. And it can be concerning because you probably are planning to use rifampicin for treatment or other therapies that might impact the liver. Well, I can tell you that actually once you start treatment, this actually comes down very nicely. You might see some leukopenia, anemia, thrombocytopenia, but often it can be normal. So these are some of the features that might show up in the case of acute brucellosis. So the treatment relies on really these 3 main pillars, if you will. It has to be an antibiotic, has the ability to act intracellularly in an acidic media, because that's where Brucella live. They live in the macrophages, and that's why duration of treatment is very long, as you saw yesterday. Combined therapy is the mainstay. Single therapy doesn't usually work. And prolonged duration. And of course, the age will impact, and this is where the pediatric guidelines come in. We'll show now. We have some limitation compared to adult treatments. This is just a list. This is actually directly from the guidelines. I just cut and paste this. This is the current therapies that are available for children, the dosing that we have, and the guidelines are readily available online. Now, this is the combinations we use. Our mainstay is rifampicin and Bactrim, or TMP SMX, for children below 8 years of age. The drug of choice and the highest success rate is doxycycline with Bactrim in those children above 8 years of age, or adults, as you saw with Dr. Mimish. We often combine, when we have severe disease, similar to our child who had CNS disease, or children who have osteomyelitis or endocarditis, gentamicin or streptomycin can be helpful in eradication, especially those who have bacteremia, eradication of the brucellosis, and get a rapid response quickly. And this is just, again, a cut and paste directly from the guidelines. I think I'd like to highlight here the endocarditis and neurobrucellosis, that combination therapy of 3 or more. And the child we treated in the initial phase, in the first few months, was on 5 drugs. And ceftriaxone, although you'll find a lot of debate in the literature, and we don't have well-controlled studies, has actually shown to be, at least in good reports and case series, to be successful. And we use ceftriaxone in our child as part of our combination therapy. And the duration can be very prolonged in these patients. Ours, as I said, is going on more than 1.5 years now, and we're following the MRI basically for response. And monitoring, I think the clinical response, I want to highlight in children specifically, the clinical response is really the way to go. Don't follow serology. I think I put it here somewhere here. I would not test serology maybe at the end of therapy just to make sure it's coming down. Because as you saw earlier, that the titer of 320 can be sustained for up to 18 months in about 25% of these patients. So just be careful. The temptation is to repeat the serology. If they're responding clinically, you're in good shape. And this is a concern. About 3 to 9% will have what we call relapse or reinfection. There's a huge debate. Dr. Mimish yesterday replied that he's rarely seen chronic infection or persistent infection. In my experience, and again, working with the National Guard, the period I was there, is that reinfection is probably the most common cause. And again, because of and we've seen this with families, the attachment to the concept of the cattle and their attachment to their cattle, and the fact that the benefit of drinking the raw milk remains a problem. I remember families, the parents who might be educated and young, complaining that the grandparents are taking their children to the farm and giving them milk despite the objection of the parents. And so, and if you take a really good history and challenge the family, you'll often see that they've been re-exposed to brucella. Chronic infection or relapse in children is very uncommon. Adults, it may be more common, but rarely do we see it in children. Control. I'm not going to go over the detail. This is not the objective of this, but just to see why it's such a challenge. And I think we often get the question as infectious disease consultants, and assuming we have, we work in committees in the Ministry of Health or so on, is that why don't you do more to control it? And why do we still see brucellosis? Well, you can see here the steps taken to control brucellosis are not easy. Dr. Rajhi mentioned yesterday this has to be some sort of national campaign. It can't be sort of individual. I actually was able to speak to one of the physicians who works with the Ministry of Agriculture and Water and Animal, I'm sure in English, I'm not sure, وزارة البيئة والمياه والثروة الحيوانية. And I spoke to one of the directors, and he said it's been very challenging to do nationwide mass campaigns. It's costly. And even the concept of telling herd owners you have to slaughter your herd has been challenging. And so they've been doing targeted campaigns. When they know there's an outbreak, they'll go do some vaccinations, try to cull and slaughter, and that's what they're doing now. The 2 big vaccine campaigns that Dr. Ziad Mimish mentioned, he was very much an advocate, and we did see a drop, but sustaining that is very challenging. It takes a nationwide campaign.
Dr. Issam, you have 5 minutes more.
I'm done, inshallah. 2 more slides. The vaccine, the animal vaccine, there are some good vaccines, and as I mentioned earlier, had we had a worldwide pandemic, we'd be way, way advanced in these vaccines, but there are many of them. But the biggest problem, the ones that are used right now with the live attenuated, Dr. Mimish alluded to that a bit. The problem with that is that some of these actually can cause disease in the animals. Some of them can cause actually abortion, these vaccines. And the herd owners know this. And the problem is that once you vaccinate them, they have antibodies. So now when you come to do your screening, the tests that we have now currently can't tell between a vaccinated camel, for example, and an infected camel. So that becomes a challenge with the current vaccines. So we need better testing to differentiate between vaccine antibodies or infection or any true infection. And then some of them have caused human disease, some of these live strains, especially in immunocompromised individuals. So it's not as easy as we think it would be. So this is my last slide, and I'll just say that again, it's trying to control it. But I think the biggest, factor is public awareness. This is something where we can do better. And we have noticed this. I mean, I don't want to be totally, many families, when they come to us and they're for the first time with diagnosed with brucellosis in the National Guard, and we give them a lot of education, many of them actually do very well. And they go to their herd, and they even come back to us. And Dr. Membish mentioned some examples. My mentor, Dr. Alola, has a huge number of these families. And they've done a great job in going back to their herds and trying to control that after they've seen what happens to their children. So public awareness is probably one of the biggest factors we can do in improving brucella, and for children also. Because again, we have to advocate for them. Children don't know. We give them something to drink, they'll drink it. But all of these require a collaborative team approach, a national approach. I think one day we'll get there. Inshallah, we're optimistic. Again, thank you so much for inviting me, and it's a pleasure to be here. Thank you.
Thank you, Dr. Assam. Now I'd like to invite to the stage Dr. Wala Al-Mansouri. Dr. Wala is a consultant pediatric infectious disease in King Abdulaziz Medical City in Jeddah. She's assistant professor of pediatric and pediatric infectious diseases at King Saud bin Abdulaziz University for Health Sciences, College of Medicine, Jeddah since May 25th, 2014. She's also a section head of pediatric infectious diseases at King Abdulaziz Medical City in Jeddah since November 2021. Dr. Wala will be talking about hot issues in the management of malaria in children. Dr. Wala, the floor is yours. تفضل.
Thank you so much, Dr. Zainab, and the organizing committee for the invitation. It's my great pleasure to join you in this conference. Bismillah wa salatu wa salam wa rasulillah. We'll start to talk about some special hot topics in regard to malaria in children. I know Dr. Hazmi, yesterday he elaborated more of the treatment and the adult and epidemiology, so I'm going to skip those points. So those are my objectives. I have no disclosure. So malaria is an ancient scourge of humanity, and it continues to extract a heavy toll of life and health in some parts of the world. Children are the most affected, especially aged 6 months to 5 years, with 10% deaths among children. Etiology, human species, as all you know, Vivax, falciparum, malaria, and oval. Those are the zoonotic malaria, which usually comes from certain types of monkeys, namely macaques, and they are usually distributed in some part of Asia, knowing the name Plasmodium knowlesi in Malaysia and Asia, and Plasmodium cynomolgi mainly in Vietnam. Other two types, rare type of zoonotic malaria, Plasmodium innoi and Plasmodium quaterni, they are usually unable to invade the human, but they can overcome those barriers by producing some proteins that are required for the erythrocyte invasion. Plasmodium life cycle is very important when we want to talk about the vaccine and the transmission and some of the act of the vaccine targets, the extrahepatic site and the erythrocyte cycle. Incubation period, just to know that parasitemia can be very high in Plasmodium falciparum and in Plasmodium knowlesi. And as you know, the incubation period usually it's around 12 days for 15 days, and it can reach up to 30 days in Plasmodium malariae. Transmission, I'll concentrate more on the congenitally acquired disease, as we are a pediatric, I'm talking about the pediatric age group, blood transfusion and organ transplantation. So malaria is endemic in 84 countries, with a death is around 600,000 deaths per year. Children of all age living in non-malarious area are equally susceptible, And endemic area children less than 5 years, they have a repeated and often serious deadly attack of malaria. And the survivors, they develop partial immunity. That's why older children and adults, they often have asymptomatic parasitemia. Of course, we are an endemic country. That's why the CDC, it is one of the recommendations that to give malaria prophylaxis for whoever coming to Saudi Arabia, and it's mostly distributed in the south region. This slide just to show that it is less frequent in pediatric age group less than 5 years of age, but it is more in those above 15 years of age and those 10 to 14 years of age, mostly because they are doing outdoor activities involved in the agriculture, mostly in the region of Jizan and the other south region. Plasmodium falciparum is the most common. In the Eastern Province, this study was done in from 2009 to 2019. Prevalence was low in the Eastern Province, around 0.63%. I'll skip this part as Dr. Hazmi elaborated already. So malaria in Saudi Arabia as of 2021, 95% were imported, 5% were introduced. Mostly we have Plasmodium falciparum. And the annual incidence rate of indigenous malaria in Saudi Arabia in the last 5 years, from 2017 to 2021, it relates mostly to the population movement, the heavy rainfalls, and all cases were occurred in the remote village in Jizan and in the borders near to Yemen. Transmission season between October and March peak, and in January through February. So clinical manifestation in pediatric can be very vague: fatigue, difficulty in breathing, diarrhea, abdominal pain, seizures, most commonly febrile seizure, more common than the adult. And this complicated malaria can be also happen in children. We'll speak about that later. So for those who were treated with cerebral malaria, they can have 25% of the survivors, they develop neurocognitive and behavioral sequelae, as illustrated in this study. And this is an adult study which is collecting several studies that showing that survivors of the cerebral malaria, they can have some neurological sequelae, cognitive deficit, and behavioral alteration. And those are children study that they showed they can have some cognitive and attention deficit, memory deficit, up to 2 years post follow-up of the recovery from the cerebral malaria. Risk factors for cerebral malaria include age, children, pregnancy, poor nutrition, and host genetic susceptibility and history of splenectomy. Among adults, cerebral malaria occurs more commonly among the non-immune individual than among those living in high endemic areas. Seizures and severe anemia are more common in children, whereas hyperparasitemia, ARDS, and jaundice are more common in adults. Cerebral malaria with coma and other severe presentation can happen in both. So we'll talk about congenital malaria. Vertical transmission, all species can happen, but it is more common with Plasmodium falciparum and Vivax. Placental infection is a prerequisite, but doesn't predict the congenital disease. Placenta infection is more common than the cord blood parasitemia, which is more common than detection of the parasites in the infant's peripheral blood. Among the immune pregnant women, transplacental malaria transmission was 1.5% versus 7 to 10% in the non-immune pregnant women. Pregnant women with the overt symptom of malaria during pregnancy, they have 1 to 4% risk of vertical transmission. And the low incidence of congenital infection, despite the high incidence of placenta infection, is likely secondary to the passive immunization via transplacental neutralization of the antibody. It is difficult to distinguish from malaria acquired as a newborn, as among infants with congenital malaria, the onset of the clinical manifestation usually around 2 to 8 weeks of age. Symptoms include poor feeding, fever, vomiting, thrombocytopenia, anemia, and hyperbilirubinemia. Splenomegaly is more common than hepatomegaly. This study was showing a case report of congenital malaria in newborn delivered to mother with malaria-infected placenta in Blue Nile State, Sudan. They mentioned that the diagnosis of congenital malaria is complicated by the low density of the parasite circulating in the cord blood and or the peripheral blood of the newborn. Molecular technique on diagnosing those kind of patients is more sensitive. And prevalence of congenital malaria by the use of PCR was studied in 102 babies born to mother with macroscopically confirmed infected placenta. At delivery time, they collected placental, maternal, peripheral, and cord blood samples in addition to samples collected from the newborn peripheral blood were examined for malaria infection using the stains, GIMSA stain, and the PCR. And as you see from the table, that they stated that 0 babies, they have parasitemia at birth, but they were positive by PCR. And the conclusion of the study that 25% from the 102 babies with congenital malaria were born to mother with both placental and peripheral blood malaria infection detected using the two technique. This is another case report from for a congenital malaria of a baby who was born, and this was reported from Kuwait. 32 days old female who presented with fever, hypersplenomegaly, jaundice. And the mother had malaria 2 years before while visiting her native country, Afghanistan, and was treated with a chloroquine for 3 days. So the conclusion that it need really a high index of suspicion should be considered to diagnose congenital malaria. How about globally? The overall prevalence of congenital malaria was around 6.9%. And this meta-analysis showed a varied prevalence of congenital malaria across endemic area, and it was higher in area with unstable malaria transmission. Okay, now we come to a blood transfusion. It's a really hidden malaria risk. Transfusion transmitted malaria, and it is, we'll mention about TTM, transfusion transmitted malaria. This report showing 2 pediatric cases from USA. And the first case was a 14-month-old premature baby who presented with RDS, and he needed ECMO, had DIC and multiple transfusion. The Plasmodium species was recovered was Plasmodium oval, and the donor was immigrated from Cameroon 2 years prior to donation. And the other patient is a 13-year-old sickler who had presented with severe symptoms, anemia, fever, pulmonary edema, and Plasmodium falciparum was found in his peripheral smear. And the donor feature was immigrated from Nigeria 4 years prior to the donation. So you can imagine how that need a high index of suspicion. In non-endemic setting, transfusion-transmitted malaria is rare, but potentially fatal and becoming more common with globalization. So we present 2 pediatric cases that demonstrate donor screening using a questionnaire is subject to error, and that transfusion-transmitted malaria should be considered with fever following a numerous transfusion. Transfusion-transmitted malaria in a preterm newborn case. This is a case report that we reported from our institution. Transfusion-transmitted malaria rarely happens in the newborn. The method used to screen the blood before transfusion vary widely, and most techniques require a minimum level of 50 parasites to detect the infection in the blood, which is difficult to achieve in the non-endemic area. We report the first preem baby with a possible TTM in Saudi Arabia. The patient was treated with IV trostinate with a full recovery. This type of infection requires a high index of suspicion, especially in the newborn baby. So what's the difference between the malaria transmitted mosquito and the transfusion transmitted malaria? In TTM, an initial symptomatic period, which is the pre-erythrocytic, which allows the activation of the innate immunity cells against malaria parasite, is not present, which makes the infection more severe. As few as 10 contaminated RBCs can be sufficient to spread the parasite, so it's a small inoculum is potentially infectious. So screening of the blood for malaria was recommended by WHO, and they required 2 methods for screening. If the initial one is positive, should be confirmed by a second one. Screening in endemic area, usually it depends on the smear and rapid diagnostic test. And in the non-endemic area, serology usually the test of choice. Transmission of malaria from a donor for a solid organ transplant. This case report was showing 3 solid organ recipients, liver, kidney, and heart, in which a Plasmodium vivax was seen in the was diagnosed in them, was documented from the same donor during evaluation 30 days after the transplant surgery. And the diagnosis of the donor-derived malaria was confirmed in all patients by smear and by PCR. Pre-transplant screening of donors and recipients from endemic region may not be sufficient to safely rule out persistent malaria. And they stated that although donor evaluation is not standardized in the current guideline, we suggest that donors be tested for malaria with peripheral blood smear, detection of specific IgG antibodies against Plasmodium, and PCR if possible. So we have in some pediatric age group, there is some group of patients who has some certain inherited hemoglobinopathy. They have a sort of protected mechanism against malaria. Namely, variant group of sickle cell, variant of hemoglobin C, thalassemias, and increased fetal hemoglobin. Hemoglobinopathies, they are protective in the heterozygous, meaning having SC disease, but in the homozygous, like hemoglobin SS, or compound heterozygosity can cause serious disease. And other G6PD deficient patient, they have a partial protection, but they are not immune against malaria, and this is a very important thing to remember. So what are their mechanism of protection? In G6PD, the mechanism of protection from malaria by increasing phagocytosis of the ring parasitized variant RBCs, and alpha thalassemia by reduce the pathogenicity through reducing the cytoadherence, and in beta thalassemia by enhancing the removal of the parasite-infected RBCs. How about in sickler patient? Impairment of Plasmodium falciparum red cell invasion and growth under condition of low oxygen tension, and enhanced removal of the parasitic infected hemoglobin S. Diagnosis, detection of parasite usually, as we know, it by smear, and it is time-consuming, need a trained personnel. It is qualitative, but the negative about it that it cannot detect very low parasitemia, less than 5 to 10 parasite. A rapid diagnostic test of malaria, it is rapid, qualitative, and selection, it depends on the epidemiology of infection. And as all in our country, we are endemic for Plasmodium falciparum, so our RDT is based mainly to detect falciparum and Vivax. PCR, it's limited mainly to reference laboratories. For the treatment guidelines, the MOH, they have published National Malaria Drug Policy in 2018, and they put as artesunate was a first-line treatment, and it was updated in the December 2022. The change of the first-line Plasmodium falciparum from artesunate was because of the Saudi Arabia, most of the Plasmodium falciparum are imported or introduced with the reported resistance in the countries where malaria infection originate. So what about some treatment consideration in children? Doxycycline is contraindicated below the age of 8 years. Primaquine is contraindicated below 6 months of age because of the hemolysis. HIV co-infection and antiretroviral treatment because of the drug interaction. And infant with a congenital HIV exposure, the WHO recommend that the patient placed on cotrimoxazole between 4 to 6 weeks of age and continue till HIV has been ruled out. It has a dual protective effect against pneumocystis jirovecii and malaria. Treatment of sickler patient. Most of the sickler patients, once they are diagnosed with malaria, they have to be admitted for treatment because of the risk of hemolysis. And the very important thing to remember that they have a high mortality, and there is a poor correlation between the parasitemia level and severity, meaning the patient can have a very severe symptoms, but a low parasitemia level because of the protected mechanism that I mentioned earlier. The drug recommended for the first and second line, Plasmodium falciparum, artesunate, and others are safe, can be used. And traveling to malaria endemic area should be given appropriate prophylaxis. For G6PD patient, we are endemic, G6PD is the prevalence in Saudi Arabia around 3.6 to 8.4%. Both infection and some anti-malaria can increase the risk of hemolysis. G6PD screening is recommended for all male patients with a severe complicated malaria and in all patients with malaria and severe hemolysis, black water fever, or renal failure. In the treatment of Plasmodium falciparum for patients with G6PD, sulfadoxine, pyrimethamine, and primaquine are contraindicated due to the risk of hemolysis. Now we come for prevention. So what are the important challenges that we face in regard to prevention of malaria? Parasite drug resistant, mosquito insecticide resistant, geographic expansion of mosquito species, and spread of parasites that do not express the protein detected by the rapid diagnostic test. Our main goal is control, as the reduction of disease incidence and prevalence. Elimination is reduction to zero transmission, and eradication is a global elimination. Different ways can be done with chemoprevention, mosquito vector control, mosquito repellent, mass drug administration, and malaria vaccine. So when we come to malaria vaccine, we have to mention again about the parasite life cycle. As the vaccine, the two WHO approved vaccine, it is mainly act on the pre-erythrocytic cycle of the parasite. And those many vaccines are approved, still in the clinical trials, but the one that we're gonna talk about is the RTS vaccine and the R21. So RTS vaccine, it was approved by WHO in 2021 for children mainly in Africa with moderate to high transmission. It's a recombinant protein based on antigen target certain sequence of amino acid in the Plasmodium falciparum sporozoite. It's in the phase 3 trial, which was showing partial protection, mainly used in children aged 5 to 17 months of age, 4 doses, with efficacy proven to be from 36 to 44%. There is no significant efficacy against severe malaria. And then R21 was launched in October 23 for children, again in areas with moderate to high transmission. R21 vaccine is a virus-like protein based on the circumpozoite protein from Plasmodium falciparum, age from 5 to 36 months of children. It's a 3-dose vaccine. It reduced clinical malaria by 75% during the 12-month post 3 doses. A 4th dose given a year after the 3rd maintained the efficacy. This high efficacy is similar to that seen in the RTS vaccine. So what is the similarity? The two WHO recommended vaccine R21 and the RTS, they have not been tested in a head-to-head trial. There is no evidence to date showing one vaccine perform better than the other, and the choice of the product to be used in the country should be based on the programmatic characteristic, vaccine supply, and vaccine affordability. Both of them, they are safe, but safety monitoring will continue. Other way of monoclonal antibody that had been used as a prevention for malaria, it is mainly used for individuals who are unable to mount an immune response to vaccination, as well as for individuals in region with emerging anti-malaria resistance in the setting of malarial outbreak. There is 2 types, one given subcut and one given as infusion. Both of them, they showed a good protection with 88%. Genetic control, they talked about yesterday by Dr. Muayyad Qureshi about genetic control, which is using a male mosquito to introduce genetic factors that prevent the eggs from hatching or larvae from surviving. This technique called sterile insect technique. And it's a mass rearing of insects take place in special facilities. They make irradiation of the male and female insects are separated. And then the sterile male insects are released over towns or cities. The sterile male mosquito compete with the wild males to mate with females. These females lay eggs that are infertile and bear no offspring, reducing the mosquito population. This technique, it has been used in some areas in Asia and in Singapore as well. So where are we from that? The Saudi National Guideline for Malaria Management, December 2022, they have intervention in the final phase of elimination and prevention of re-establishment. And by that, with no reported indigenous transmission of malaria in 2021 and 2022. So it requires a particular intervention for mass implementation, and they are doing that by targeted drug administration, targeted testing and treatment, intervention in response to the detection of the confirmed malaria cases, and reactive case detection. And when I'm reviewing the form, it's really a very precise, about everything to control malaria in terms of epidemiological data, personal data, parasitological data. It's very intensive and very precise. And by that, I think we deserve to have the E-certificate of E2025 initiative by the WHO. What is the meaning of that? It's the malaria eliminating countries for 2025 initiative. It was launched in 2021. And it includes 25 countries and 1 area. The selection of the E2025 countries was based on criteria just as having a government-endorsed elimination plan, meeting a defined threshold of malaria case reduction in recent years, and meeting a predefined program requirement and expert opinion, including from the WHO. So in Saudi Arabia, there is 2 consecutive years with a 0 indigenous cases in 2021 and 2022. So it was nominated for the E2025, as you see, the country of Saudi Arabia has been nominated. So what's the future vision in 2030? KSA is a malaria-free country, inshallah, and this will be achieved by a continuous great expert effort and contribution of all health sectors in different regions will reach our vision. There's no voice?
دائما نضرب فيه المثل اسمه جبل طويق. لدى السعوديين همة مثل هذا الجبل. همة السعوديين لن تنكسر إذا نهد هذا الجبل وتساوى بالأرض.
By that, thank you, and كل عام وانتم بخير. Thank you.
Thank you, Dr. Ola, for this informative, engaging presentation. We'll move to our next speaker, Dr. Hatem Al-Hani, Dr. Hatem, Pediatric and Infectious Disease Consultant at Maternity and Children Hospital in Dammam. He is a member of Command and Control Center in Eastern Province, Director of the EP Infection Control and Preventive Medicine, Vice Chairman of Emergency, Disaster and Ambulatory Transportation General Department in Eastern Province, Head of Scientific Team Center for Outbreak in the Eastern Province, Head of Infection Control Department at Maternity and Children Hospital, Dammam. Welcome, Dr. Hatem, and he will give us talk about addressing the TB management decision in pediatric patient. The floor is yours.
السلام عليكم. صباح الخير جميعا. شكرا جزيلا مجموعة الموسى الصحية for invitation. I'll talk about TB is one of the problem, and I feel it is growing at our community as we are changing the face of our population. Now, every one in new tuberculosis infection every second, 1/3 of the world population is infected, and approximately 4,500 people will die today from tuberculosis. Now, the children are having special problems in dealing with TB. Now, the definitions or the classification is interactive, and the limitation is all based on the presentation, capability of diagnosis, and the treatments. So we have at least, you could say previously, the WHO were classifying as smear positive culture positive, smear negative culture negative, or smear negative culture negative. But now we have interaction with the new investigation tools and the knowledge, accumulative knowledge of diagnosis. The WHO has reporting the number of death and impact globally of tuberculosis. As you see, almost 200,000 deaths related to TB in children yearly, 80% in children less than 5 years, and this is one of the major challenges we are seeing. And there is almost 96% of death in children who did not access TB treatment. The problem in the kingdom here, now we have, look at Philippines, look at India, Pakistan, Bangladesh, Nigeria, and other African countries. They are all coming to us. They are at our homes, they are in the restaurants, they are drivers, and we are in continuous contact. Our children are in contact with them, and they are increasing numbers, and it will be reflected in our contact rate as well. Now, unfortunately, the WHO reporting increasing in TB rate comparing to the previous. There is a history of decline. From 2020, they are reporting increase in the rate of TB reporting everywhere. Now, you see here the mortality related to TB is higher than the death estimate related to HIV and AIDS compared to COVID, and again is 1.1 million a year mortality related to TB. Here again, the death of TB in 2022 almost double those from HIV AIDS, and which continued to fall. Now here, usually this is the United States, reflect the site of infection related to TB between 1993 and 2015, and you see lymphatics is dominated, meningitis and central nervous system related infections constitute almost 4%, miliary, bone and joint. In 2021, still lymphatic is dominated. There is pleural, bone and joint, peritoneal, and others. Now here it is almost, we have similar representation, our pediatric population. Now here, this is the, between 2018 and 2023, this is our eastern province, between Abageg to Al-Khafji, and I think we have a problem here of under-reporting, especially in the special population pediatrics. If you see to this role that between 0 to 5 years, hardly we reach in 2029, 2022 6, and 2023 only 3. Between 6 to 15 years, you see the population among these age group is 8, 7, 10, 9, 4, and 7. Now, hopefully, with the new regulation by the ministry, where Hussein is mandating, and we have another way of reporting through directly to the lab, it will improve the reporting. Now, see, the gender distribution is dominantly as expected in male, and Saudi to non-Saudi almost double to treble every year between the non-Saudi to Saudi. And extrapulmonary TB, it is high compared to the pulmonary sputum negative and dominated pulmonary sputum positive. We have a problem again with extrapulmonary report in the region. Now, in pediatrics, we have 40% of TB cases are undiagnosed, long treatment duration with multiple antibiotics, 6 to 12 months, and no effective vaccine that prevent transmission up to now. Now, the first item, most cases still diagnosed by sputum smear, which is a technique is more than 120 years. Long treatment duration is drug-sensitive TB cases still treated with the policy of 1970s and developed regimen, and the BCG vaccine is still oldest vaccine from 1920. And a lot of work has been tried to change this one, change the diagnostic modality, the duration, and the vaccination development projects. And these are really the major challenges in pediatric: how to improve your diagnostic facilities, how to reduce and improve the compliance of treatment, and how to develop effective vaccines. And there is millions and millions now in the globe invested in vaccine. I think last year there was at least $1 billion has been spent on the vaccination line to improve the efficacy and reduce the side effect of the BCG vaccine. Now, the pathway between exposure, infection, disease, and outcome, and knowing the risk factor and intervention at different stage is all the daily work and effort at different levels between governments, institutes, and physicians to work on. Now here, the transmission, usually we look at the household contact, and there is a proportionate relationship between the degree of contact with the adult, and mostly adult, is the source of infection, and the risk factor whether the patient is immune compromised or not. Now, usually the age group in infant, we are seeing here in the kingdom, compare also to the world, that the maximum risk group are children and infant less than 2 years. And we have increasing rate of complicated late presentation and dissemination over the last 5 years, and it is expected to be in that way. Now, the highest risk is the first 6 months after infection and remains high for the first 2 years of life. Of course, the immune compromise is a predisposing factor. We have 2 peaks in pediatrics, and this the green rows, those are positive investigation, whether tuberculin or IGRA. The second group are negative, and the red group are mix of both. So you see that less than 5 is dominated, and then between 15 and 18 to 18 groups, and they are the big incident everywhere. Now, this is the usual presentation, less than 1 year, and 1 year to 2 years, they are constitute the majority, almost 40 to 60%. They present in this age group, and also those less than 2 years, the highest to have extrapulmonary like CNS, opponent joints, and miliary TB as well. Now, this is the usual or the estimated time table of TB in children, and this is the month and related to the presentation, and usually the bronchial or respiratory, pulmonary, or pleural, fusion, miliary, and renal, and these are the time frame between the exposure and the symptoms appearance. Now, the presentation of TB in children, it is the big challenge. Usually it is non-specific, and we have seen children most of the time as a screening test or after delayed. Now, the interpretation of tuberculin, skin test, or IGRA depends on the age factor, and we are seeing fever, cough, neck mass, wheeze, weight loss or bore weight gain, lethargy, fatigue, and reduced activities. And these are the TB symptoms which are showing to be very greatly. Fever is not a dominant. Pediatrics, we should not rely on fever in assessment of these children. And a lot of studies showed cough, persistent cough, or cough is the first and most common presentation in pediatric age group, and these are excellent studies showed that among other other pathogens related to their presentation, whether acute cough with delayed recovery, recurrent acute cough, or persistent non-remittent cough, persistent cough related to TB is the commonest among other symptoms. Now, the key message here, clinical diagnosis of TB disease is not difficult in children. Bacteriological confirmation of TB disease is difficult in children. And we always struggle to get a biopsy or take a tissue biopsy for diagnosis. And the limitation here is well known. Diagnosis of TB disease in children require a high index of suspicious. Now, usually we look at adult, and we should insist that adult contact is there all the time. Now, for radiology or for correlation between the pathway of TB and the investigation we do between the uncomplicated lymph node or even adult type pulmonary disease, which sometimes we see, especially in adolescent, you have a progressive focuses, lymph node diseases with bronchopneumonia and so on, to pleural fusion, and depends at what time you start investigation, you expect the manifestation on X-ray. Now, we know there is limitation in X-ray at different stages of diagnosis. Case verification, this is between, again, United States study 1993-2015, clinical diagnosis was the majority in 52%, provider diagnosis 22%, and lab confirmation is only in 25%, and this is among almost 20,000 cases. Now, this is reflect how it's difficult to look at the definitive diagnosis in pediatrics, and especially the younger age group. We should start early. Time is very important and critical, and you go empirical a lot of times. Now, chest radiograph, it is carry a lot of limitation because of the good technique, experience with children, and we advise all the time to view a BA and lateral, and careful interpretation is very essential. Now, we often see the lymph node is the leading there, but in AB view, so many times we cannot see it. Intendation or indirect visualization of adenopathy through a compression of a large airway, you should look at it very deeply. You should discuss it with the radiologist all the time. And lymph node in the lateral view compared to the BA or AB views is very common in there. Now, tuberculin test and IGRA, of course, tuberculin may be negative in 10 to 40%. And here we are strict who's supposed to do it and who supposed to interpret the tuberculin skin test. IGRA may be negative, and sensitivity is at maximum 85%, and it is controversial for children less than 2 years and does not distinguish between infection and TB disease. We look at the microorganism in different sites. Now, previously we rely only on gastric aspirate or tissue biopsy, but now the nasopharyngeal aspirate, they are a good study, and the WHO recommending it. The oral swab, tracheal aspirate, bronchoalveolar lavage, gastric aspirate and lavage. Stool recently has been approved by the WHO with appropriate technique, string test, laryngopharyngeal aspirate or oropharyngeal aspirate. Now, there is a lot, I'm sure we are aware of most of that, the rapid test, sputum microscopy, fluorescent microscopy, histopathology, and we have the PCR based. The latest is the line probe assay, nucleic acid amplification test, and some other tests here. Now, the latest, these are a list of a lot of study. They are trying to work up that to make the sampling easy to look at and make it more accessible and easier for use. We know the timing of result, limited of detection, sensitivity in children. Smear and microscope is as low as 10%, culture is up to 40%, and the expert Mycobacterium TB rifampin ultra, which is the latest, is at maximum of 30%. Now, there is a lot of trial to develop a new technology to help to collect the sample, and here there is a lately, they are trying to let the baby aspirate, a respirator, and through the filter, they take the filter and try to explore it there in the lab, and it showed promising result as well. Now, a pathway or make it easy that at each group, like children less than 5 years of age, prefer tuberculin stent test, and IGRA or tuberculin test is acceptable. Likely to be or infected with low or intermediate risk of progression, IGRA where available is the preferred or acceptable IGRA and tuberculin test. Unlikely to be infected, we prefer IGRA where available, or either IGRA or tuberculin test. For serial testing, either of them are acceptable. The treatment modality is very clear. It's available in the American Academy Red Book. Now, again, the target is to try to improve the compliance by shortening the duration as much. 3 months, 4 months is much better than 6 months or the previously, either for latent TB or for active disease. Now, the isoniazid plus rifampicin has been approved for 12 weeks, daily 4 months for rifampicin, isoniazid plus rifampicin for 3 months, and the conventional isoniazid 6 months or 5 months. And with different, this is the American Academy Read Book has been clearly mentioned with different group. Here is some our experience. I selected some patients, showed this is a young child who presented to us. This is less than 1 year, was diagnosed as hemophagocytosis. He had hepatosplenomegaly, required ICU admission with, as you see, cavitary disease, infected, a close contact was seen, and when we took a biopsy, it was TB. After 1 year therapy, he was immune competent. Major risk factor for disseminated and severe disease is young age. This is another child of 2 years old. He presented after 6 weeks of fever, lethargy, and weight loss, and he had disseminated to meningitis as well. The hallmark was missed initially. This is another child. He presented to us comatose, and we struggled to diagnose him. This is his basic chest X-ray, and this is the clue for us. He had small lytic lesion at his hand, and we took a biopsy. It was positive for AFP. Now, it is good response to treatment, coma, sitting, and walking, strabismus improved, some motor deficit, and cognition was not yet premature to assess, and permanent sequelae are common in this. 50% is the sequelae, and the mortality, it depends on when, at time of presentation. Now, TB in the very young is rapidly progressive to BB disease. Last year, we had 3 African children. They presented less than 5 months of age, and both of them, they unfortunately died. They have disseminated. One of them presented in coma again. Now, his father, and this is a lesson to be learned. His father is working one of the restaurant. He was diagnosed as pulmonary TB. Nobody screened the family, and nobody gave prophylaxis. He had another child. He was also, when they come to us, he was diagnosed as latent TB. For TB exposure, the young child, the more urgent the need for prophylaxis. Now, this is another 8 years old, close contact. Chest X-ray was normal, and his Mantox was 22 millimeter, and he was asymptomatic. Subsequently, he had developed wheeze, and this was his all the parenchymal infiltrate with lymph node. This is wheezing in a 1-year-old child. He tried all type of bronchodilators, steroid, and he is not responsive. When he came to us, we worked him up, and it was again TB case. Segmental pneumonia, result of bronchial obstruction, we are seeing it very frequently. We are seeing again skeletal. This is a back pain and limb in diabetic adolescent, and it showed that it is spinal TB. Every year we are seeing 1 or 2 cases of spinal TB. Now, this is a 12-year backache. This is his mother. We diagnosed him through his mother. He presented with a lump in the back, and he had backache for 1 year. He loved football, and he fall down at the school, and he brought him. He did biopsy some other hospital, and they said it is granuloma non-specific, but his culture was not done there. He came to us, unfortunately, we diagnosed him as TB. Now, fever, weight loss, multiple node in chest, abdomen, and fully sensitive, strain, and this is his abdomen. He had abdominal mass, and it was TB abdomen in this adolescent. This is another pulmonary TB in adolescent. He had cavitary lesion. This family, his father has MDR, and another 3 family member had TB as well. A pleural fusion, frequently we are seeing TB presentation as pleural fusion, may be part of a primary disease with marked hypersensitivity or rupture of subpleural foci, cough, non-productive, fever and chills, biopsy and culture of fluid, and it is important in 75% yield.
Dr. Hatem, you have 5 minutes more.
Yeah. We had frequently TB lymphadenitis, and the struggle is how to differentiate it from non-tuberculous mycobacterium. This is a child who had taken biopsy from his lymph node, and he started discharging and lasted for at least 5 months with this picture. This is a high school child with a skin lesion, chronic skin lesion, and turned to be a TB sensitive strain. This is a sickler, and he came with chronic osteomyelitis, and he was diagnosed empirically as chronic osteomyelitis. A lot of antibiotics given, and we end up to us with a biopsy, and it was proven to be TB. What is the message here? We have a TB with all the spectrum of disease in the kingdom, and we have to look at deep. And with the changing of the society, we are open more and more. We expect more cases of HIV and more cases of TB, and this is my message. We need to improve our diagnostic facility. We have to suspect it all the time, and thank you very much.
Thank you, Dr. Hatem. And now I'd like to invite all the speakers to the stage. Dr. Banyan, Dr. Wala, Dr. Hatem. And the floor is open for questions and discussion. تفضلي دكتورة. عليكم السلام ورحمة الله.
Wafa Nasser, ID from Dammam. My question to Dr. Wala, how do you know, you mentioned that we didn't have any indigenous cases of malaria in 2021 and 2022. How do we know it's not under-reporting, especially with the COVID effect? Because like in National Guard, we're seeing among battalions malaria almost every year. So how do we know or make sure it's not really under-reporting?
Thank you. Thank you, Dr. Wafa.
Thank you, Dr. Wafa, for your question. Really, it's a good question. It is really maybe it's a sort of bias, especially with Yemen, with the closure border of the Yemen, but it is mostly reported by the Ministry of Health data. So this is a real data that which was based on that, we were having the recent updated guideline in 2022, and maybe there is a sort of bias that because of the closure of the border, but as per all of the studies and the data published by the MOH in the website, that this is the real data, and we don't have any cases for the 2 years in consecutive years, 2021. So, but maybe your question, because maybe it's biased because of the imported malaria, but this report was of indigenous malaria, not of imported malaria. So that's why we deserve the E-certificate from the WHO, mainly for indigenous malaria. Yes, yes.
Any more questions?
Thank you to all the speaker. Question to Dr. Isam. Are there any statistics for about in our Saudi Arabia about brucella susceptibility for the first line or alternative to the antibiotics? In our area in Al-Ahsa, we face it is less commonly than in Riyadh, maybe 2 or 3 cases per month. Most of them respond to the first and second line treatment, but we face cases that after 2 to 3 weeks of the first-line treatment, the patient does not improve clinically and serologically. And often change to the Cipro and rifampicin, very well respond the patient, but not respond to the Bactrim and Rifam or doxycycline. And thank you.
Thank you, Hassan. You may have seen Dr. Ziad actually put up his slide. It was very nice showing the data that there was some rifampicin, sometimes resistance, for example, especially rifampicin, up to over 20% in some of the report. He showed a table yesterday, I think. And even quinolones, by the way, and he was very concerned about the overuse of quinolones. And there was a question, I think, about limiting the use of quinolones overall because of its impact on diseases like, non-tuberculous mycobacteria, et cetera. So even quinolones, we're seeing some resistance. Now, the good thing is, again, I think the first line, in pediatrics at least, even if you see resistance to rifampicin, to be honest, we still use rifampicin and Bactrim. We have the susceptibility just as a backup, just in case there's no response. But believe it or not, and even when we see resistance in vitro, in the patient, we see a good response. Now, I agree with you. The clinical is the most important. Forget the serological. If he's not, usually children with that, they respond within a few days. You see, it's like magic, and they're up and walking and feeling great within 3-4 days. If you don't see a response in about a few days, a week, then I agree. You have to switch. Quinolones might be your option that you're going to have to use. And there are other options. You might have to bring them in. You have to reevaluate. You saw how different systems can be involved. I think you have to be, thing I would caution against is just simply switching. A good reevaluation is required. Bring them in, reevaluate. They may have, bacteremia still. We've seen endocarditis. We saw the CNS disease. So I think the message is to reevaluate those who are not responding. Which antimicrobial to choose? You can always call ID anytime. We're happy to help. The most important when you see a child not responding is to have a good reevaluation. Thank you.
Yes, just a short comment about the resistance of Brucella to rifampicin. There's actually no cutoff point for rifampicin, so they use Haemophilus influenzae as an alternative. So I really question the things talking about resistance.
Thank you. I think you explained it from the lab standpoint, and really that's why I think we see a lot of discrepancy between what we see in the lab. The cutoffs, the published, established cutoffs are not very clear for brucellosis, and I think this is very nicely explains why we don't see sometimes the correlation between in vitro and in vivo. So I would still recommend using rifampicin and Bactrim as your first choice in children, unless you have severe disease or you need other drugs and so on. Thank you.
We don't prefer to use rifampicin in adults because we want to use them in TB. That's why we prefer Bactrim.
وبعدين صححني بس adults livers حقتكم حساسة يا adults انتوا. Whenever we start rifampicin, you see often children they tolerate rifampicin and INH much better, I think much better than adults. But I agree. Doxycycline would be a much better choice than and Bactrim in adults. I think is probably the first line that you use in adults, if I'm not mistaken, for brucellosis.
So in general, like if we go to TB, we see less hepatotoxicity in rifampicin in comparison to INH or pyrazinamide. So it's actually a safe drug. Yeah.
I love rifampicin as a combination with for many diseases.
No questions. I have one question for Dr. Isam. Thank you for this. It was a very important topic about the Brucella. I want to, as we know, the Brucella fact to be endemic in Saudi Arabia since 1980s. It's become clear that it's endemic. But still, as you mentioned, Dr. Isam, about the public awareness of the seriousness of the brucellosis as a human disease, we face a lot of cases in our clinic that they are not realized that the seriousness of disease. They took the medication, they took the course, and there is re-exposures again for either to the animals, not to ingest raw milk. We still, but we treat him again. at what level to overcome those issues. يعني at a physician levels, عبارة عن ministry levels, national wise, other architectures, Ministry of Health, Public Health, social worker we involved also, but with your experience, we need your experience to overcome these issues and improve our...
Thank you very much. I think it's very challenging. I mean, we have people in this room who maybe give us input. Dr. Ziad Ams, I think, was one of the leaders in the Brucella, the fight against Brucella, if you will. But it's a very big challenge. And I think a lot of it, I go back to both what Dr. Ziad mentioned, Dr. Rahman mentioned. A national campaign is something that's required, and it's very difficult to do that, to be honest. And I can see the challenge where governments would have to address all of the things we hear, malaria today, we hear to TB, and all these campaigns. And I actually put this up here. This is from your conference, Dr. Zainab. You have a comment from Peter Hotez. I don't know why you should have it up here every day, I think. This is from the brochure that from the AIDME, and this is Dr. Peter Hotez. He's a very prominent pediatric infectious disease physician, but he's also a vaccinologist, and he develops vaccines, and he is one of the leaders of the anti-vaccine campaigns. And he was under a lot of threat, especially during COVID. He even had death threats against him, and his daughter has autism. And he wrote a book, stating, the title is Vaccines Did Not Cause Rachel's Autism. But the statement he made here, and this goes back to your comment, is that, and I'm just reading from your brochure, I didn't know he made this statement, Yani. As a global society, we have to figure out how to walk and chew gum at the same time. We've got to take care of COVID, I mentioned that, Yani, but we really must not lose the momentum we've had for neglected tropical diseases. So I think we have to learn how to take care of disease like COVID, which nationally here, I think Saudi Arabia did an amazing job, probably the best in the world, in my opinion. But we have to learn how to walk and chew gum, yani take care of COVID, but also take care of diseases like Brucella or malaria or TB. It's not easy, but it has to be done, inshallah.
Okay, thank you. The other question, Dr. Isam, regarding the reinfection, did you treat it with the same course, 6 weeks?
I'm sorry, with the
with reinfection with Brucella. Did you treat
the CNS infection?
Reinfection.
Reinfection.
With the Brucella after excluding the
Thank
focus.
You. Yes. Yeah, usually if it's a reinfection, and we can confirm it's a reinfection and not relapse. And to be honest, we've had rare relapse, or usually have a great response, and either non-compliance, that's an issue that I think Dr. Ziad mentioned, and we see it in our family, non-compliance is an issue. But if it's a reinfection, we usually the same regimen. Try to give the same regimen again. Dr. Sheikh mentioned, Dr. Hassan mentioned the challenge sometimes of resistance, but usually we gave the same regimen again. If we see failure, then we start looking at alternative regimens. And talking to our adult colleagues, sometimes they have other alternatives that can help.
Thank you. I have one question for Dr. Hatem. Thank you for presenting the TB topics in pediatric. I want to ask some neglected part of the long-term effect of the pulmonary TB in the pediatric, because some paper they released that there is long-term effect of the pulmonary TB regarding wheezes and poor lung function or decrease in lung function and decrease in weight and impact. Actually, we didn't focus that much in following the patient, but do you have your experience with those things, complication of the long term?
Thank you very much. I think this is one of the area needs to be more focused and more work on it. We have limited, honestly speaking, limited pulmonary function test at pediatric site group. We have limited pulmonologists and pulmonology labs. But at the national level, I'm not sure with anybody had experience or published data about the long-term sequelae, which is really a point need to be focused on. In 2022, the WHO has mentioned the sequelae, and part of their target for concentrating on minority or TB in minority is to look at the sequelae. One of them, the CNS sequelae and the pulmonary sequelae. I am sure, if you share me some of your experience, it would be love with that.
Okay, from my side, I have one question to Dr. Hatem and one thought maybe to be shared with Dr. Isam and the whole room. For the vaccine, BCG vaccine, We know that the direction from Ministry of Health and the Vaccine Committee that it will be removed from the routine vaccination because of low incidence rate in the coming maybe 5 or 6 years. We know that it was deferred from birth to 6 months because of immunocompromised issue, but now with the direction of Ministry of the touristic direction of Saudi Arabia, I think the rate of TB will be increased again. So what's your thought in regard to BCG vaccine, to be removed or to still have it in our routine vaccination?
This is really debatable and controversial, but if we have improved our policy for those comers from outside, we have a restricted policy for screening them, for following them up. Probably, I think at this stage we are premature to eliminate BCG. I know there is a lot of international effort to improve the vaccine. Bill Gates has allocated $2 billion last year on the new researches on the new vaccine for tuberculosis. For me, we are premature to say no unless we consolidate our policy to secure our population from those coming, and we are very close contact with them actually.
دكتور ولاء تقول لا تشيلوا الفاكسين صح؟ I'll be devil's advocate. أقول شيلوه. I'm not sure to be honest. I mean, data is always the core. We don't have a lot of data on what the impact of the BCG vaccine is on, and that's difficult to study. But I can tell you that the amount of, even though they postponed it till 6 months, and before 6 months it was a disaster for our primary immune deficiencies. And I think the fact they moved to 6 months is a great move. But right now I think many of the side effects we see and so on, I'm not sure how protective it is. I think I think mentioned yesterday in our talks that if we control TB well, Hatem touched this, if we control TB, children get TB from adults. And if we are able to control the TB in the adult population, it's a disease of epidemiology. Controlling the adults and doing good contact investigations and controlling, yesterday I asked a question just if there's mass screening for LTBI. It was more of a challenge question, but if you control TB in the community, and we've done a great job. I've mentioned it went from 15 per 100,000 to 8 now per 100,000. So we're getting there. So maybe in 5 years, done, inshallah. No need for BCG, inshallah. أعطونا 5 سنوات.
And the issue of eliminating BCG vaccine totally from our vaccination schedule, knowing that we are Saudi Arabia with pilgrims all over the year coming from everywhere. So there is still an ongoing risk of exposure from whether it's not from within Saudi population, it's usually from non-Saudi population, and we are seeing that. We are seeing many patients refer to us for TB screening, TB treatment, latent TB, and all of the exposure were from the housemates or from a driver or from, so it's this. Still there is an ongoing risk, and knowing that Saudi Arabia, it's the target religious area from all the world, people are coming and visiting. I don't think really to consider it now with the ongoing risk, I don't think this is a really a good decision, but we'll see, time will see. Thank you.
Thank you. The other thought is about the guideline for brucella. We've been using the clinical guideline that was endorsed by Saudi Pediatric Infectious Disease as a reference for many years, and it's an excellent guideline. It's very clear and concise. But for congenital brucella, I don't think we have any good reference from our region to be followed. What to do for the mother, for the baby, when to retest, breastfeeding issues. I think calling out of all experts on pediatric infectious disease to develop a clear guideline for us.
I agree with you, and that's why it wasn't included. I believe there was not a strong agreement on exactly what the best guidelines were, and you won't find good international agreement, and because the number of cases are very few. But I agree. I mean, there's something we should address. It's too bad we don't have Dr. Remo, the head of the SPIDs and the other groups who are developing these, but we should take this on, inshallah, and hopefully come up with something better, because the guidelines do not include congenital brucellosis.
Question to Dr. Hatem. Thank you for your excellent presentation. We face some pediatric cases that delivered outside of Kingdom with their family outside and came at the age of 1 year, 2 years, did not missed the vaccine of the BCG. In this cases, did you recommend to do BBD test before the vaccine, or will give him vaccine directly, because there is a lot of controversy? What do you think?
Well, the guideline is to do BBD skin test before giving them, and I will go with that, because there is no point in giving the BCG if they have a positive BBD skin test, which is reflected infection, the exposure, and they acquire it. That's my opinion.
So in the adult population, there is a lot of new articles on the host-directed therapy for TB. Is there anything in the pediatric age group, by which I mean by the host-directed therapy is correcting some parameters that may enhance anti-TB treatment, and like vitamin D, controlling blood sugar, statins, such thing?
I'm not aware of any evidence for that, especially vitamin B is well known, especially for breastfeeders. In pediatric age group, you have less than 1 year, it's highly recommended. Other than the other modality, I'm not aware of it. If anybody have information on that.
Okay, thank you very much. I think we'll conclude here. Thank you, our speaker, for this very great, engaging presentation. Thank you.
Thank you very much for this great discussion. Now I would like to invite Dr. Muhammad to recognize the speaker and moderator, Dr. Assam Baniyan. دكتورة ولاء المنصوري. دكتور حاتم العاني. دكتورة غاية الجرينيس. دكتورة زينب الموسى. Now we'll have break for 15 minutes. We'll come back here at 10:45 inshallah.
Assalamu alaikum. We will start the sixth session, neglected but not forgotten. So let's introduce our first speaker for the first session. Dr. Mazen Berri, Associate Professor, Consultant Physician, the Division of Infectious Disease, colleague of medicine, King Saud University and King Saud University Medical City. The topic will be about leishmaniasis in Saudi Arabia, where we are stand now. Welcome, Dr. Mazen.
Thank you very much for inviting me to speak in your prestigious conference today. So we'll proceed. Let's see how this works. Okay, so this is the outline of my talk. First, we'll have an introduction, looking at the sources of disease and the life cycle of leishmaniasis, the different clinical forms, the epidemiology and molecular characterization of cutaneous leishmaniasis in the Kingdom of Saudi Arabia, or KSA, the distribution and molecular characterization of leishmania in sandflies in the kingdom, and looking at visceral leishmania in the kingdom, past and present. So leishmaniasis is a neglected disease caused by Leishmania species, which is a single-cell protozoa of the kinetoplastid origin, transmitted by the female sandflies of the genera Phlebotomus in the Old World and Lutzumia in the New World. And there are at least 93 different sandfly species that are known vectors of the disease. The global prevalence of leishmaniasis is 12 million, and about 2 to 2.5 million cases happen every year. And there are more than 20 different leishmania species that can cause leishmaniasis. These are the different subgenus of leishmania. The ones that are underlined are the ones that are commonly associated with disease. Most commonly in our region is Leishmania major and Leishmania tropica. And the subgenus Viania are the one that causes mucosal leishmaniasis, mostly seen in India, as well as in Sudan and in South and Brazil. There are two sources of disease, which includes zoonotic leishmaniasis, in which different wild and domestic animals are considered to be the main reservoir hosts. And these can be very important in the transmission cycle, and they include different hyraxes, canids, dogs, as well as rodents like the black rat, Rattus rattus, as well as anthroponic leishmaniasis, in which humans are the main source of the infection. You all know this famous life cycle that was published by the CDC, looking at the life cycle of leishmaniasis, in which it starts, how do I point out here? Just trying to get the pointer. I'm trying to figure that out. Well, I guess there's no pointer. Okay. So as you can see here at the top, the sandfly first takes its blood meal, and through its proboscis, it ingests the promastigot into the skin of the human being, or in the case of visceral leishmaniasis of the dog, and then the promastigots are phagocytosed by macrophages and different cells within the body, like mononuclear cells, and then these promastigots transforms into amastigots, in which they multiply and then they rupture and infect various other cells, and in which the sandfly comes and takes its next meal, and hence completing the human stage, and the sandfly stage starts. And these are the different animals that can play an important role as reservoirs. This is a very nice map showing the distribution of the endemicity of different Leishmania species that was published in CID back in 2016. As you can see on the top, we could see trying to get the pointer working. Does anybody know how to use the pointer? Yeah. Huh? Nobody knows how to use it? All right. Oh, well. So in the top, we can see the Old World, which includes the Middle East, and Saudi Arabia is endemic mostly with Leishmania major, and in the lower parts with Leishmania tropica near the subtropical regions in Saudi, like Asir and Jizan. The rest of the world has different species, especially that in the New World, in which we see an endemicity with Leishmania brasilensis, mexicana, and guyanensis. So the clinical forms includes cutaneous leishmaniasis, mucosal leishmaniasis or spondia, which are seen by the Viania subspecies, and visceral leishmaniasis, otherwise known as Kala-Azar. There's also some unusual syndromes, including post-Calazar dermal leishmaniasis, leishmaniasis recidivans, in which you have a recurrent of disease after healing of the original cutaneous lesion, diffuse cutaneous leishmania, disseminated cutaneous leishmaniasis, and bubonic leishmaniasis, which can mimic the plague. So it has, clinically, has a variable incubation period, but usually several weeks, and usually can present either subclinically or clinically. It starts off with getting papules that can progress to nodules, then they ulcerate, and then there's a central depression with raised indurated borders. This can happen over a few months and sometimes even up to years, and if left untreated, it can leave an atrophic scar. However, some lesions may not ulcerate and they can persist as nodules and plaques, and some patients may have more than one primary lesion and they could have some satellite lesions. Usually these lesions are slightly painful or they can be itchy, and they can be super infected with bacteria. So cutaneous leishmaniasis, either localized and diffuse infection, can appear as obvious skin reactions. The most common form is called the oriental sore, which is caused by the old world species, Leishmania major, tropica, and euthopica. And the cutaneous infections are quite common here in the kingdom. So to diagnose it, you need to take a biopsy, a deep punch biopsy at the edge of the ulcer, and you scrape the center to do an impression smear, staining it with Giemsa stain. You do a histopathology, PCR, and culture. There's also the leishmanine skin test, which is similar to the tuberculin skin test, depends on a delayed hypersensitivity reaction to the promasticate suspension antigens, which are species specific according to the different species and areas of endemicity. And it's usually positive in most cases of cutaneous and mucocutaneous leishmania, but is negative in Ethiopica and diffuse cutaneous leishmania, and is negative in visceral leishmaniasis unless it was treated successfully. This test is quite useful in epidemiological surveillance, and indicates positivity if there was previous exposure to leishmania. And however, the leishmanian antigen is no longer produced under the good manufacturing practices anywhere in the world. However, it is being investigated for use in an interferon gamma release assay, or IGRA, similar to TB. So treatment is determined by the severity of disease. So basically, if it's mild, you may want to observe it. However, if it's complex disease, which is defined as having more than 4 lesions and or a lesion that's more than 5 centimeters in size, or the lesions are over cosmetically sensitive areas, or over a joint, or failure of treatment, or there is substantial local or lymphatic nodules or large lymphadenopathy, in which you can treat either by giving local treatment using paromomycin ointments, heat therapy, which is quite painful, or using intralesional antimony. In more complex disease, we could use systemic antimonies, liposomal amphotericin B, as well as miltefosine in some cases. Visceral leishmaniasis infections are often recognized by fever and hepatosplenomegaly, as well as anemia, and they are known by many names, local names in different countries, but most common is Calazar, and is caused exclusively by the species of the Leishmania donovani complex, Leishmania donovani and Leishmania infantum, which is also synonymous with Leishmania chagassi. And it's found in tropical and subtropical areas of all countries in the world except Australia. So the incubation period for visceral leishmania is between 1 and 2 months, and up to 10 years sometimes, like some of the veterans that returned from Iraq had it. And it could be asymptomatic, subclinical, acute, subacute, and chronic. Usually has an insidious onset with low-grade fever, progressive splenomegaly with hepatomegaly, anemia, wasting, pigmentation, nodes, and intercurrent infections. A first reported case in KSA was back in 1953 in Dhahran Hospital, as you can see down there. This is the clinical features. So usually seen in children, more than 44% is seen in those less than 15 years of age, 22% in those less than 9 months. Fever and wasting is universal, and there's non-specific symptoms include loss of appetite, spleen, being uncomfortable, cough, epistaxis, diarrhea. The most common clinical sign is splenomegaly, which is 98% seen in children, 93% in adults, followed by hepatomegaly and lymphadenopathy. So to diagnose it, you'll have a pancytopenia. Serological tests are only useful in visceral leishmaniasis, not cutaneous, in which you could do an indirect hemagglutination test for IHAT, you could do an ELISA, direct agglutination test, and a quick rapid K39 dipstick. However, this test has been recently discontinued. Parasitologically, we can aspirate the spleen, which is no longer recommended, or a lymph node, or bone marrow, or liver. The Leishmanian skin test is negative, so not useful, and you could do also molecular testing. This is Leishmania dunovani in the bone marrow smear. So this is a paper that was published in IGID exactly 20 years ago by Prophet Ja'far al-Tawfiq et al., looking at cutaneous leishmaniasis, a 46-year study of the epidemiology and clinical features in Saudi Arabia between 1956 and 2002. There were 1,862 patients with cutaneous leishmaniasis during this time period reported to the Saudi Aramco healthcare population. And as you could see in the graph to the right, again, I don't want to point here, but I guess you could see that all the cases were started within the 70s, maybe one retrospectively diagnosed in the 50s before it was known to be in Saudi Arabia. And there was annually about 30 to 40 cases every year. And it affected males and females equally. In the majority of cases, about 3/4 were in children, and disease usually affected the extremities more than that of the face, and 71% of patients had only a single lesion, and up to 90% had ulcerative lesions. This is a very interesting review paper by Dr. Abu Zaid et al., including Dr. Abdullah Asiri and Professor Zaid Mimish, looking at cutaneous leishmaniasis in Saudi Arabia, which was a comprehensive overview, in which they described that Saudi Arabia first described cutaneous leishmaniasis back in 1973. Back then, Saudi was among the top 10 endemic countries globally, and in 1996, it was reported that 90% of cutaneous leishmaniasis all over the world occur in only 6 countries, including Saudi. However, the MOH established the National Leishmaniasis Control Program, or NLCP, back in 1978. As you can see here in the graph, that since the 80s, there has been a steady decline in the number of cases over the next 2 years, until Saudi Arabia was no longer among the top 10 highest endemic countries worldwide. However, it is still the 4th most endemic area within Western Asia. And within the same paper, they looked at the number of cases that were reported in the year 2015. And as you see, that more than 150 cases were reported in most central areas of the kingdom, including Riyadh, Hail, Al-Ahsa, and Medina, and about 1 to 150 cases in the south and northern regions. They also looked at the different geographical distribution of anthroponic and zoonotic leishmaniasis. So zoonotic leishmaniasis was mainly seen in Al-Ahsa and Riyadh, while anthroponic in Asir, while Qasim, Medina, and Taif had mixed anthroponic and zoonotic leishmaniasis, while the remaining areas were unspecified. They also looked at the distribution of the different sandflies by the different regions in Kingdom of Saudi Arabia. They found that the phlebotomous species, Phlebotomus papatsi, which is the vector for Leishmania major, is in all regions of Saudi Arabia, as you can see on the map on the right side, except in the southern region of Najran, Jizan, and Al-Asir, in which these areas were predominantly had Phlebotomus sargenti, which is the vector for Leishmania tropica. Also, Phlebotomus sargenti was also present, as you can see in the map on the left, also present in some of the provinces in the west, including in Medina, Taif, and Mecca. So this is a paper that was published in Parasites and Vector, titled Cutaneous Leishmaniasis in Northwestern Saudi Arabia, Identification of Sandfly Fauna and Parasites, in which they collected 384 sandflies in September 2015 to October 2016 in Ha'il region. And out of 75, both males and female sandflies underwent molecular testing. I'm not really sure why they decided to also test the male sandflies. They only found 5 or 6.6% to be infected. 2 were Phlebotomus papatsi, 2 were Phlebotomus kazaroni, and 1 was Sargentomaia clydii. They also looked clinically at 25 cases of cutaneous leishmaniasis. They were all due to Leishmania major, and due to budget restraints, they weren't able to test the remaining sandflies. This is a very good study that was published in Experimental Parasitology back in 2010, looking at the molecular characterization of Leishmania infection in sandflies from Al-Madinah Al-Munawwara province, Western Saudi Arabia, in which they collected almost 2,900 sandflies in Al-Madinah back in 2010, and they had mostly were Phlebonomus papazi, in which 1,057 were females and 1,673 were males, and 71 female Phlebonomus sergente. They did DNA extraction followed by nested PCR with internal transcribe spacer 1 or ITS1 PCR with restriction fragment length polymorphism or RFLP, and were able to identify that 23.7% or 62 of the female Phlebonomus papazi were positive for Leishmania major, while 31% of the female Phlebonomus sergente were infected with Leishmania tropica. The same group also published another study in IJID in which they did molecular testing on 34 out of 105 clinical cases of cutaneous leishmaniasis, in which they applied the same ITS1 PCR with the RFLP as well as kinetoplast DNA PCR. They found that there was a mixed cases of both Leishmania major and tropica, and they found that the kinetoplast DNA PCR had a high sensitivity of 90%, but a low specificity of 61%, with the ITS1 PCR had a higher sensitivity of 70% and 100% specificity. Interestingly, the parasite culture had only a 39% sensitivity and smear only 55%. A more recent paper by Dr. Al-Ra'i that was published in 2022 looking at the molecular characterization of a Leishmania species among patients with cutaneous leishmaniasis in Asir province, Saudi Arabia, in which there was an outbreak of cutaneous leishmaniasis back in 2021. They identified 194 cases, 38% were children, 75% suffered from a single lesion, 60% of the lesions were on the face, 58% were from Khamis Mashayt, while 28% originated from Abha. And then they did a Bayesian phylogenetic tree generated with 39 ITS1 sequences. And those other sequences in the map there is in blue, and you can see that in the south, due to the predominance, there was predominance of Leishmania tropica due to the known vector of Phlebonomus sergente, and Leishmania major was more prevalent mainly in the northwest and center of Saudi Arabia, in which Phlebonomus papazi is the main vector. But as you can see in the lower part of the graph, that there are two cases of Leishmania major in Asir, which suggests the high diversity of the ecology of the sandfly vector within the Asir region. Also a study that was published in the prestigious journal Scientific Reports in 2022, looking at the genotypic and phylogenetic analysis of cutaneous leishmaniasis in Al-Ahsa, eastern Saudi Arabia during the COVID-19 pandemic. First, cases of Leishmania tropica with the predominance of Leishmania major. As during the lockdown period, they noticed that there was a huge surge of sandflies observed in Al-Ahsa, probably looking for the blood meal that was lacking. And they did skin biopsies and from 100 different patients who had no travel history over the past 6 months. And then they did impression smears followed by a 3-step PCR protocol using genus-specific primers targeting the kinetoplast DNA as the first screening step. Then they do 2 genus and species-specific PCRs, including the ITS1 PCR and then ITS1 nested PCR. And by using the latter, they were able to identify 98 cases of cutaneous leishmaniasis out of those 100 cases. And Leishmania major was the predominant species. However, they identified 3 cases of Leishmania tropica. And the direct ITS1 PCR had a sensitivity of 91% and 100% specificity, while the nested PCR was able to identify the remaining negative cases by the ITS1 PCR. This table just briefly look at the difference between Leishmania major and Tropica. The ones that reached statistical significance was the difference in the distribution of the lesions, as well as the clinical outcome and family history. Another study that was published in 2019 in BMC Public Health, looking at the prevalence of Leishmania species among patients with cutaneous leishmaniasis in Qasim province of Saudi Arabia, in which they did 206 skin biopsies and then underwent quantitative and qualitative PCR for identification of the different species. And they found that 49% were due to Leishmania major, while 28.6% were due to Leishmania tropica. And they found that 8 cases, or 3.9%, were due to Leishmania infantum Donovani complex, which is the first time to be detected in the Kingdom of Saudi Arabia.
Dr. Mazen, 5 minutes.
All right. This is another study that looked at leishmaniasis in KSA, epidemiological trends from 2019 to 2021, which was a retrospective analysis of the data from MOH surveillance and registry database. There were a total of 2,763 cases, mostly in Al-Medina region, followed by the eastern region, Hail, Asir, and Hafr al-Batin. However, you can see that there was the number of cases in Medina was 46 in 2019 and dropped to 147 in 2021. This is an interesting systemic review, Leishmaniasis in Saudi Arabia, current situation and future perspective, that they did between 1989 and 2018 for cutaneous leishmania and visceral, and they said that cutaneous leishmania represented the most frequent clinical form and mainly endemic in the regions we already mentioned, and that there's no demographical or socio-economical restriction as affected both urban and rural citizens alike, and majority occurs in farmers, and as discussed, mainly due to Leishmania tropica and major. These are the 10 different studies, including in the systemic review. Only 3 used molecular testing, but they only had kinetoplast DNA PCRs or small subunit ribosomal DNA PCR. And the biggest study was back in 1989 by Dr. Zahrani et al., looking at 2,302 cases in Al-Baha and Asir and Western region, followed by Al-Ahsa with 901 cases back in 2009 and 2010. Both used only direct parasite detection from skin smears. They also looked at visceral leishmaniasis, in which they found that Leishmania donovani was the main cause of disease, and infantum was the main cause in animals, and dogs were considered the main reservoir hosts, and the black rats, Rattus rattus, were also identified as potential hosts. And it mainly affects children here in Saudi Arabia as well as infants, and the diagnosis is often by either invasive parasite detection procedures or by using serological testing by the indirect hemagglutination test, and these are the 6 studies included. The biggest study was by Jamil et al. From Asir, in which and the study period was quite long, between 1985 to 2008, with 582 cases. There's a more recent study in 2014 published in PLOS Neglected Tropical Medicine, titled Leishmaniasis in the Middle East, Incidence and Epidemiology. And they noticed, as you can see in the graph in the lower left corner here, that in pink, the number of cases of visceral leishmaniasis steadily dropped from the early 2000s due to the introduction of the National Control Program. Finally, this paper that was published by Dr. Abu Zaid et al., including Dr. Abdullah Asiri, looking at visceral leishmaniasis in Saudi Arabia from hundreds of cases to 0. And they noted that most cases are in the southwest region, mainly Jizan and Asir, and Leishmania donovani is the main cause, and Leishmania infantum have been isolated only in dogs from endemic areas. And however, they found that the vector was Phlebotomus orientalis in this study, and the black rat, Rattus rattus, also was found to be contributing to the maintaining the life cycle of the parasite. And again, they found that it primarily affected children, and these are the regions of the kingdom with reported to have visceral leishmaniasis in the past, mostly in the south, and very few cases, maybe 7 or 8 cases in Medina and Tabuk. So the development of the National Leishmaniasis Control Program, or NLCP, which emphasizes on the early diagnosis and provision of prompt treatment with notification of suspected or confirmed cases to the NLCP within 24 hours through Husn, and upon diagnosis of a new case, there's a visit to the community conducted by an epidemiological and surveillance team, and there's primary vector control by and other also means of control. So this is just the graph looking at the annual number of reported cases of visceral leishmaniasis cases that were reported to MOH from 1980 to 2009. So by 1985, you can see the peak there was, 1988 was about 305 cases, and slowly the cases dropped until 2019 was the first time to detect zero number of cases. And actually, in a more recent published paper, which actually it's not a published paper, it's the guidelines for the treatment of visceral leishmaniasis by the Public Health Deanship of the MOH in September 22, reiterates that the zero number of cases even in 2020 and 2021. However, that didn't stop them from updating the treatment guidelines. So in conclusions, in 1973, KSA was among the top 10 endemic countries for cutaneous leishmaniasis globally. The sandfly Phlebotomus pipazi is a vector of Leishmania major, are predominantly Medina, Hai, Al-Qasim, and eastern regions. And the sandfly Phlebotomus sergenti, vector of Leishmania tropica, are predominantly in Asir and southern regions. And recent cutaneous Leishmania cases by Leishmania tropica in the east and by Leishmania infantum donovani complex in Qasim. And MOH established the NLCP in 1978, which caused a significant drop in the number of cases until Saudi Arabia became no longer within the top 10 endemic countries in the world, but still the fourth most common endemic area in Western Asia. And the number of reported visceral leishmania cases in KSA dropped from hundreds in 1980s to 0 in 2019 until now. That's all. Thank you.
Thank you very much, Dr. Mazen, for such interesting review of such topic. Now we are going to present Dr. Hawra Al-Bayat. She is an infectious disease consultant in King Saud Medical City, Riyadh. Dr. Hawra, she finished his residency and her fellowship in Prince Sultan Medical City, and she is a well-known figure in infectious disease in Saudi Arabia with a lot of publication. Today she is going to speak to us about Madura food. I'm sure that we are going to enjoy such a presentation. Go ahead, Dr.
First of all, good morning, everyone. Thank you, Dr. Badr, for this great introduction. Thank you, Al-Ahsa Health Group, for inviting me to be speaker in this amazing meeting. So, what's our topic? I think we never touched this in any meeting before. It was really hard for me to review such a case. I saw only one case in my life. It was in King Faisal Special Hospital, and the patient, I think he was on antibiotic, the lifelong suppressive therapy. So my outline, I will start with a case scenario, introduction and the distribution about the Madura foot, symptom and the sign, risk factor, diagnosis, and finally the diagnosis and the management. So 3 Indian male, the age between 40 and 60-year-old of rural background, presented with a chronic multiple discharging sinus of the foot. They were initially treated for several months in their local center without any improvement. Many investigations were done for them. MRI and histopath examination was done for them as the usual scenario for such a patient. They were referred across various departments such as dermatology, GS, orthopedics, and eventually they got corrected diagnosis. So the name Madura foot is derived from the South India city of Madura, where it's said to be first reported in early 19th century. This picture, which described this Madura foot, it was written by 20th century as done by Tribidi and Mukherjee in 1939. What's mainly the distribution? They call it the Madura belt. It's mainly in the Venezuela, Chad, Ethiopia, Yemen, Sudan. Also, it can involve the Mexico and Thailand and Yemen. The transmission, mainly the bacteria and the fungi, they cause mystoma, which lives in the soil and the water. These germs can enter the body through the wound or the other small skin injury like a thorn prick. Mystoma doesn't spread between the people. What's the mainly causative organism? The Madura foot can be classified to a two subgroup, actinomystoma and eumystoma. Most common location of this infection is a foot, which causing around 70%, but it can cause the infection in other sites such as the back, arm, leg, and hand, also reported in some cases. Mystoma, it's typically presented in agriculture worker or in individual who walk in a bare foot in the dry, dusty conditioner, which can allow the pathogen to enter the skin from the soil. Actinomystoma, it's caused by a group of filamentous bacteria, which is commonly Neisseria, Brucelliniasis, and Streptomyces madura are the most common causative organism. In a rare cases, Neisseria asteroid can cause pulmonary nocardiosis, but also it can cause mystoma. And actinomyces israeli, commonly they cause actinomyces produce mystoma on the foot or even in the hand. Eumystoma, it can caused by a group of fungi with a thick sepitated hyphae include Escherichia bodii and Madorla griseae and Madorla mystomii. Usually, they have a large incubation period. It can reach up to 5 years. In early disease, usually the patient will present with the painless, firm swelling of the foot. Following these, it will appear the classical triad of chronic induration, draining, sinus, and discharging granules. Sinus, it's usually developed after 6 to 12 months and extend to the fascia muscle, and it can distract the bone. Rarely there is a lymphatic dissemination of regional lymph node, and usually the actinomyces mystoma expanding faster than the eumystoma and more invasive, more sinus than the eumycotic variant. So here we have this schedule. It might give us a hint regarding the color of grains, whether we are dealing with the fungal or the bacterial type. So in eumystoma, they classify two black grains and the pale grains, and the most common pathogen which can cause the black grains like mystoma griseae, mystoma mystomaceae, leptospiridia groups, and there is some other species it can cause the black grain, while the pale grain like bodii, aspergillus also, aspergillus flavus, and fusarium species, it can cause the pale grains. In actinomyces, they divide it to 3 groups, either red grains such as Actinomadura betyliteriae, or the yellow grains such as Streptomyces sommeliniensis, and the pale grains such as Nocardia brucelliniensis and Cavis and Astrodoides. Also, regarding the morphology, it can give us some hint in morphology and the related species. In eumystoma, they divide it to Amadorlia mystoma. It's usually a large granules with interlacing hyphae embedded in the interstitial brownish matrix. And in Petroleum bodii, it's usually eosinophilic, lighter in a center. It can be differentiated between the other species. One is small and the other one is large, and the other one is a lighter. In actinomystoma, the actinomadura, it's usually large, between 1 to 5 millimeter and larger, multilobulated with peripheral basophilia and central basophils. And it's usually a pale staining, filamentous growth from the peripheral zone. Streptomyces is usually large, and even larger than 2 millimeter with a dense thin filamentous, often stain homogeneously with a transfer fracture line. In nocardia, it usually appears like small central purple zone, loose clumps of filamentous, gram-positive branching filamentous into a bacillary and cochlear form. So, a gram stain is considerable a value to differentiate between actinomyostoma and the eumystoma. The fine branching filamentous, about 1 millimeter and thick, or it's usually accompanied with the grains of actinomyostoma. And in actinomyostoma, it's usually gram positive, while in the eumystoma, it's usually gram negative. So this histopath, it shows us neutrophilic infiltrates with the agiant cell, which surrounding the actinoma, which surrounding the cells. Also, this is a thin actinomyostoma, and this is a thick clumps which is appears in the eumystoma. So the difference between the actino and the eumystoma, one of them it will appear as thin and the other one is the thick. There is some other differential diagnosis before we reach the diagnosis. It can mimic the chronic bacterial osteomyelitis, TB, or even early phase of Burley ulcer. Other fungal infection, especially in the other area like in US, it can be present as mimics blastomycosis or coccidomycosis. Also leishmaniasis, yaws, and syphilis can be considered in such cases. Differentiation between actinomyostoma and eumystoma is important for the treatment response and even to consider the surgical management. Eumystoma only partially responds to antifungal therapy, but it can be treated by surgery due to their normally well circumscribed nature. The surgery in combination with the azole treatment is a recommended regimen for small eumystoma lesion, which is, if it is mainly it's mainly caused by medullomystoma, can be respond to ketoconazole, but Buddii may respond to itraconazole. Other agents of eumystoma may respond intermittently to itraconazole or amphotericin. So, actinomyces mystoma combination drug therapy is a must, and the more effective component is the trimethoprim. And it's better to be combined than use the trimethoprim sulfamethoxazole component alone. So the preferred regimen is to use trimethoprim sulfamethoxazole, 48 milligram per kg per day, BO, almost for 4 weeks cycle, plus either amikacin, 15 milligram per kg IV for 3 weeks, or streptomycin plus daptomycin for a month. Alternative regimen, if the patient he has sulfa allergy or he is not tolerant, amoxicillin clavulanic acid, imipenem celestatin, meropenem rifampin, but usually we don't recommend to use rifampin as a monotherapy due to the higher resistance to this regimen. Surgical intervention is rarely needed, should be avoided, but amputation and debridement and excision may be necessary for the diagnosis of actinomyces mystoma. In eumycotic mystoma, the preferred regimen is the itraconazole, the dose between 200 to 400 milligram BID, with the duration 6 to 9 months. Surgery is recommended. Wide excision may be needed if insufficient response. Other alternative antifungals such as voriconazole, posaconazole, and terbinafine is also can be used in some cases. So there is only some literature review about the Madara foot. I found this treatment of Madara foot. They did a systematic review, The objective, they measure the best available evidence about the effective treatment of Madara-Foot. They review about 31 studies. They include in the review 27 cases and 4 cases series they included in this systematic review. Total was 47 patients were analyzed. 25 was due to eomystoma and 21 cases due to actinomystoma, and 1 had both. They divided to the dose of sulfa drug, trimethoprim, sulfamethoxazole, and dapsone. Amikacin tetracycline also was administered for treatment of actinomyces. And the azole derived, such as itraconazole, ketoconazole, voriconazole, fluconazole, miconazole, as well as employed the drug for eomystoma. The resolution of the disease was about in 88% of included patients. The surgery was performed in a total of 20 patients, with the resolution of disease in all cases. The overall resolution rate following therapy was 95%. So what's the clinical message regarding the Madara-Foot? The Madara-Foot is a chronic depleting disease which can be readily diagnosed based on striking clinical triad of a painless swelling, draining sinus, and excretion of grains. MRI of finding of a dot in a circle, it gives us a clue regarding the disease. Treatment with antifungal should be continued at least 12 months, even if the disease have resolved earlier. Thank you.
Thank you, Dr. Haura, for the nice presentation. Now the next presentation will be about addressing neglected health by Dr. Abdul Hakim Al-Thaqafi. Dr. Abdul Hakim, Consultant Infectious Disease, Department of Medicine, King Abdulaziz Medical City, and he is a Joint Program Director for Infectious Disease, Second Sector, Western and Southern Region. Welcome, Dr. Abdul Hakim.
شكرا جزيلا. السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله. First of all, I would like to thank the organizing committee for the kind invitation to be among this prestigious speaker for today and yesterday. And really, I learned a lot. And it is really a very high scale conference or symposium. I don't know why I was the only one who was given 2 parasites to talk about, while others, they are given only 1. Anyhow, inshallah, in the next 20 minutes or so, I'm going just to refresh your memory about neglected diseases that all of us actually exposed to in the second year of medical school when we took our parasitology course. Since then, only few cases were seen. And I'm sure that a lot of others share me this, and seldomly I saw any case of strongyloids. Anyhow, this is my objective for today. I'm going to touch bases of osteomyelitis and then schistosomiasis, tackling epidemiology, clinical presentation, hyperinfection syndrome and treatment, screening and prevention. As well, we'll talk about the epidemiology of schistosomiasis and in Saudi Arabia as well, and the geographical distribution, as well as the clinical presentation and management. Then we'll just shed a light on the WHO strategy for schistosoma control. This is the strongyloid stocharias, which is a thread worm. It is a nematode that has 2 larval form. One is rhabdiiform larva, which non-infective form, and is a free-living stage that can survive outside the host. And a filariform larva, which is the pathogenic infective form, which it can be found in the human host. And it has a unique character that it has a free-living stage and a parasitic stage. And both stages are the female, no wonder. The size and shape of the worm are dependent on the weather and the parasitic or free-living environment. The free-living are smaller than the parasitic females, and that's because the parasitic one, they have a good nutrition inside our body. And the eggs are very, very small, 55 micrometers, so it can be missed easily in the stool examination. Epidemiology, the disease is found worldwide. There was an estimated 50 to 100 million cases reported in the WHO. It favors the warmer side of the tropical and subtropical areas. It is endemic in the sub-Saharan Africa, Latin America, Southeast Asia, and the southern United States. It shares almost same maps which was mentioned before in these tropical areas, where health care provision is really seldomly accessed. Worms can be free living in the soil or live in a host. Only female form are parasitic, while male, the definitive host is human, but may also affect other primates as dogs. So they contribute to the persistence of the life cycle of the parasite. Habitat, the parasitic adults, they reside in the duodenum and jejunum of a man. The larvae, not the eggs, are passed in the human feces, so it is the diagnostic stage. The infective larvae found in the soil, intestine, and the perianal skin as well. And the main mode of transmission is skin penetration by the larva when people walk with a barefoot in the area. This is the classification. It is a nematode with a family of Strongyloididae, and the species is Tricolaris. This is the life cycle. We don't have a pointer as well in here. There is a pointer, but it doesn't show on the screen. We'll start from the bottom, which is number 1. This is the diagnostic stage. It is the rhabdidiform larvae, which present in the intestine and can be excreted in the stool. And for those who are in the endemic area, they are really very well trained to detect these and to differentiate it from other hookworms, as well like the Ascarius and the other nematodes. When it reached the soil, it developed into free-living adult worms, which produce an egg. This egg contains the rhabdidiform larvae, and it hatch due to heat and other environmental factor. And this is the infective state when it reaches to the either skin of the human body, or it can be ingested as well. When it penetrates the skin, it travels with the venules and the circulation to reach to the intestine. And the falciform larvae start to reproduce within our human body to produce the adult parasitic female in the small intestine. And this can have an egg which passes through the stool, or it can hatch as in the falciform, and it causes an auto-infection. So the parasite can reside in the human body and complete its cycle and re-infect the same host multiple times. The disease has a direct parasitic life cycle. The parasite has a direct life cycle, meaning it can complete the entire life cycle within a definitive host. This causes an auto-infection because worms keeps infecting them without leaving the body. And with the abundance of this cycle, it can cause disseminated strongyloiditis and hyperinfection syndrome, especially in extreme age people, either elderly or very little one, immunocompromised host, or those who has immunosuppressive drug. The massive larva invasion in the tissue, like the lung and the serous cavity, can reach to a devastating disease. And sometimes the intestine wall and the colon wall itself can be penetrated, and this leads to translocation of our colonic bugs into the systemic circulation, causing a secondary fatal bacterial infection. Usually this, without treatment, this state leads to a fatality rate of more than 80%. The symptoms, usually the disease itself, the infection itself is asymptomatic. But when symptoms occur, it depends on the tissue involved. If it involves the gastrointestinal, the patient can present with diarrhea, abdominal pain, and malabsorption. It works like the hookworm, actually. It resides in the duodenum and jejunum, so it really sucks blood in there. When it penetrates the skin, it can cause ground itch and can cause rash as well. And sucking the blood within the system cause anemia as well. People with weaker immune system, elderly and little children, they are susceptible to the hyperinfection or disseminated strongyloiditis. How do we diagnose this disease? By direct microscopy, detecting the rhabditiform larva in the stool. The larvae are seen in the stool approximately 1 month after the skin penetration, and you may need up to 7 times stool sample examination to reach to do more than 90% of the sensitivity. You can see eggs as well, but it is more difficult than the larvae form, and larvae can be seen in the sputum as well. And there is a serological test, either standard agglutination test or hemagglutination test to detect the antibody against this organism. It can be seen in the tissue if you have a biopsy. Only adult worm and eggs and larvae can be seen in the intestine, while in the lungs, only the larvae form can be seen in there. How do we treat this condition? Ivermectin is the drug of choice. Dose of 200 microgram per kilogram per day for 2 days, usually for mild, moderate cases. The ivermectin binds to the chloride ion channel of the parasite itself, causing hyperpolarization and paralysis of the bug and render it ineffective anymore. And it affects only the adults parasite. It doesn't work on the larvae or the eggs. And the cure rate usually is 97%. The second line of drug, which used to be the drug of choice before the ivermectin, which is the albendazole, which is a universal antiparasitic agent. We give it in the dose of 400 milligram twice daily for 7 days. And the very old component of it, the thiabendazole, which is not, at least in Saudi Arabia, available now, was the second line drug before that. We need to treat the host more than a week for 2 to 3 weeks for the hyperinfection syndrome, and usually it can be life-saving, but still, even with the treatment, the mortality is still considered to be high. So physicians should be particularly diligent to consider screening in patients who are or about to begin corticosteroid therapy or other immunosuppressive agent. People with weakened immunity like HTLV or HIV infection, people with the hematological malignancy, leukemias, lymphoma, who are undergoing intensive chemotherapy or who are subjected to transplant, people going for organ transplantation as well, or those who have unexplained xenophilia. This should trigger really a physician to look for this organism, especially in those people who are coming from endemic area. The prevention in general, to prevent the soil pollution by sanitization, improvement of sewage infrastructure, and really improve the general environmental health approach in those countries. The WHO really advise people in the endemic area to wear shoes and to avoid walking with a barefoot in the waters in there. As well, case finding and surveillance with identification of carrier and disease patient to give them promptly treatment in order to decrease the burden of the transmission, as well personal hygiene like hand hygiene, gloves and gowns for those working in the hospital when they deal with such patients. Let's shift gear and talk about schistosomiasis. It is the second most prevalent tropical parasitic disease in the world behind the malaria. WHO stated that 200 million people in 74 countries were exposed to this disease or diagnosed with this disease. More than 60% of them, 120 million, have symptoms, and it causes severe illness in 20 million persons. Between 200 to 800,000 deaths per year were reported due to this disease. First, it was described by Theodore Belhars in Cairo in 1851. The disease is often associated with water resources development projects like dams, irrigation schemes, freshwater reservoir, artificial lakes, cultivation of rice, because there is a lot of fresh water in order to cultivate rice. And usually it resides where the snail intermediate host of the parasite breed. I remember when I was in my elementary school في الابتدائي in my countryside, which is south to Taif, we used to see the snail in the fresh water in there. Now the area is dry. But then I learned when I entered the medical school, maybe 6 years later, that it was Benzolaria arabica. And I remember when the control program started for bilharziasis in our area, that the Ministry of Health came and labeled the wells, al-abiyar, with the letter ba bil-Arabi or B in English, which is bilharzia, well, يعني بير فيها bilharzia, according to the snail. And that was really a very extensive program in the area, and we'll see how it goes to reduce this disease. This is the known parasitic species with its geographical distribution. Of concern, we have 3 mainly parasites that infect humans. The other, they are very limited to some pockets of Africa. The Schistosoma mansoni, which is the intestinal one, are residing in the Africa, Middle East, Caribbean, and South America. And the Schistosoma hematobium, the urinary one, they reside in Africa and Middle East and India and Turkey. And these 2 species were reported in Saudi Arabia. The Japonicum actually in the Far East, and the other, they are limited to some part of Africa. And this is the maps which explain the area of infestation or the area of presence of these 3 species. اوكي زهير السباعي الله يذكره بالخير ان شاء الله طول عمره اذا كان موجود لسه, was one of the eminent public health people who really extensively published in this in the last maybe 3 centuries ago. And this publication was in 1988, where he described the prevalence of the bilharzia at that stage, with the left-sided table explain different area overall prevalence. And he reported that Al-Baha has the highest, which is our area in there, highest prevalence at that time. That report was launched like 2 or 3 years after the start of the control program. The control program started in 1976, same time as Mazen mentioned, which is the Leishmania program, 1978, because they at that time they make the program as a vector control program as an existing body in the Ministry of Health. So he has, in the same publication, actually he compared the incidence which was published like 10 years before his paper, and the prevalence dropped down from 46 to 6.5 within a span of 2 years. So that it was really a good achievement. I didn't find in the article itself any EBI curve, unfortunately, but if he put it in EBI curve, it will be really very representative. Till lately, in 2020, a group from University of Hail, I think, his name is, I cannot see his name, Zureg, Rifat Zureg. He described the overall prevalence over a span of 7 years from 2014 to 2020. And in both reports, you can see that the schistosoma reside in the left side, on the west side of the country. The eastern province, they don't report any schistosoma. So even Al-Ahsa, which it has a lot of, used to have a lot of free water, that's because of the absence of the snail itself. It's not present. So 20 years or 30 years later, the same area which was reported in Al-Sibai publication was the same area where they really reviewed the Ministry of Health statistical book for 7 years, that it is the same area which reported, but with much less incidence. And still the highest was Al-Baha, 16.4 cumulative incidence rate. But when I try to recalculate the 100,000 population, the rate dropped down from 0.6 to 0.012. So that's really a huge drop of the incidence and the prevalence of the disease. This is the life cycle of the schistosomiasis. Again, start from the diagnostic stage, which is the eggs, and there is a characteristic shape of the eggs, which we call the spine. It is a central spine in the hematobium, lateral spine in the mansoni, and a round egg in the jabonicum with no spine. The eggs reach to the fresh water, where it hatched to meracidia. Meracidia develop in the snail after penetrating the cell into the infective state, which is a sporocyst. They produce the cercaria, and this cercaria, this is the one which is responsible about penetrating the skin and causing the swimmer itch, we call it, and start to reach to the portal vein through the venules. Initially, it causes the schistosomuli, and it is with the growth, it reached to the portal vein, where it established its life cycle to the adult worm and reside within the sinuses of the liver, and it start to lay egg and to reach to the intestine or the urinary bladder, causing the systemic disease. The acute schistosomiasis, after the penetration, we call it Katayama fever. It presents with fever, headache, generalized myalgia, right upper quadrant pain, tender hepatomegaly, bloody diarrhea. It can reach to the lung as well, causing respiratory symptoms due to the 70% due to schistosoma mansoni. It causes interstitial pneumonia, which can be seen in the X-ray. As well, the portal hypertension causes splenomegaly in 30%, where it causes pancytopenia, and sometimes it could cause rarely aseptic meningitis. The urogenital hematobium present with hematuria. Basically, the eggs lie within the mucosa of the urinary bladder, causing a lot of nodules, continuous inflammation and irritation of the area, where it can be a carcinogenic, and afterward it can cause urogenital cancer, and this can present with all the cancer stage. The intestinal phase, mansoni and jabonicum, they can cause a disease in a slower pace than the hematobium one. Allahu Akbar. And it causes a progressive enlargement of the liver and spleen as well. And the portal hypertension itself causes varices around the lower esophagus part and fundal of the stomach and around the rectum. And people can present with really massive upper GI or lower GI bleeding. And I remember when I was in 10, we saw a lot of these cases even during my medical school. And we used to insert something called single staking tube. I don't know if anybody knows single staking tube. رفع يده. يلا اللي في نفس سني يعرفوا single staking tube. تمام. It's an NG tube with two balloons, where I used to do it when I was an intern. You ask the patient to swallow like an NG tube, and you pass it till you pass the stomach fundal. Then you inflate the two balloons, and you bullet. The balloon of the stomach one will close the hiatal varices, and the esophageal one will close the varices till next morning when the hepatology come, or the gastroenterology to scope the patient. And usually some of the bleeding was really fatal. You cannot control it. It's a massive bleeding. كأنك فاتح pipelines كده. How to diagnose this disease? It's mainly by detection of the eggs in the stool or urine. You need 3 samples sometimes because of the intermittent shedding. If you are lucky enough, you may see xenophilia in the blood film. And usually all sort of anemia were reported in schistosomiasis, iron deficiency, anemia of chronic illness, macrocytic, microcytic, and macrocytic anemia as well. Biopsy of the intestine or the bladder can show the eggs in there. It is really the most sensitive diagnostic test. If it was read by an expert histopathologist. Usually it performs in patients with typical clinical findings, but negative feces or urine samples. And usually you may see the eggs within the venules of the intestinal mucosa.
5 minutes,
are
دكتور عبد
available.
الحكيم.
كم باقي؟
5 minutes.
5 minutes. أخذ لك دقيقتين أنا إيش رأيك؟ طيب, useful in specific circumstances, the eggs can be in the katama, you don't see eggs, so you can use the serology. The problem with the general serology is that it is not sensitive or specific. There is an immunoblot assay which is only available in reference lab, which detect the antibody against the either egg or the worm antigen, which is highly specific and sensitive. How do we treat schistosoma? The only way to reduce the disease symptoms is by treatment. There is a standard dose of the praziquantel, 40 milligram per kilogram, single dose, or you can divide it twice. This for the Mansoni and for the hematobium as well. Japonicum, you need 3 days treatment, but we don't see it in here. And there is oxaimmunoquine, but it is sensitive only for Mansoni. It doesn't work in the hematobium. Prevention, again, educate the people not to urinate or defecate in fresh water supply. People who live in Egypt, فاكرين شو اسمه محمد رضا لما يقول طول ما نعطي ظهرنا للترعة عمر البلهرسية في جدتنا ما ترعى. ما في أحد من مصر هنا. طيب. That was really very famous دعاية 10 سنوات عشنا عليها واحنا صغار. احنا في جدة كنا نشوف البث حق مصر. فنشوف الدعايات هذه. انتم محرومين في الشرقية. طيب, again, eliminate snail vectors by making water habitat unsuitable for the circaria living. Remove vegetation, increase the water flow, يعني avoid the stagnation of the water itself. Provision of safe, adequate water supply and sanitation. Provide by water to avoid direct contact with circaria. And prevent swimming في الفرش. Now we start to see more cases. Dr. Saada and myself were in the flight from Jeddah, and she told me about last year they saw a young from Taif who was swimming after الأمطار في الغدران اللي around the Taif, and he has an active schistosomiasis. So we have to be aware again of this disease. Of course, mass drug treatment of the communities reduce the reservoir of the infection, and it can prevent that. Now I'll shift to the WHO because of the sake of time. I'll give you this is a very thick document where it is written very nicely. On the left side, there is a list of 23 neglected diseases. It doesn't show on the screen. This is the roadmap for neglected tropical diseases 2021 to 2030. You'll find it in the WHO website. It's very nice document. On the left side, you see the targets, which was stated for all tropical diseases. They aim for 90% reduction of patients diagnosed with neglected tropical disease and 75% reduction by the 2030 reduction of morbidity or mortality related to the disease. They aim to 100 countries to eradicate at least one of those 23 cases, and they need 2 neglected diseases to be eradicated by the 2030 from all the globe. This is the element of the plan itself, composed of 4 steps: integrated approach, multi-sectorial coordination, universal health coverage, and country ownership of the control program itself. And there is a good chapter about schistosomiasis where they have a summary of the burden of the disease, geographical distribution, statistic about the cases, prevalence, and incidence, and they really have one table about the core strategic intervention, which composed of 6 steps: preventive chemotherapy for all those disease or population, WASH, which is sanitation and hygiene, vector control with the removal of the environmental the source of the disease itself by modification, increase the sewage infrastructure, and involvement of the vet to reduce the burden of the disease in the animal and to avoid zoonotic transmission, and of course case management with mass treatment and other like behavioral change, self-care, and environmental management intervention. With that, I conclude. These are the references which is used in the presentation, and thank you very much.
Thank you very much, Dr. Abdul Hakim. Can I invite the speaker, please, to come to the podium for a 10-minute discussion? Thank you. Any questions يا جماعة؟ تفضل دكتور. Do we have the mic?
Thank you very much for this amazing presentations that highlights the really neglected infectious disease. I have two small questions. First, we are talking about the neglected infectious disease. Most of medication used to treat such diseases, we are having difficulties in finding it, especially in maybe in small cities. Maybe in central cities like Riyadh and Jeddah, it will be available more. So even something like albendazole or mebendazole, for example, baromycin, is not available in most of the hospital. Until now, we don't have a real pathway for getting those agents. Second, small things we are moving toward innovation in molecular testing. Now with the gastrointestinal panels and the PCR test, we are finding more and more of positive for parasitic infection. How this would, in real life, tell that this patient have an active infection, or it is just a positive test from a previous infection who could be treated a long time ago?
First of all, I agree with you 100% of the availability of the drug. Ivermectin is really very seldomly you can find it. We find a difficulty to provide it for one patient of us with a really devastating disease of Norwegian scabies. And the albendazole, it is available. I don't know, maybe because we are dealing with it, because it is the drug of choice of hydatid disease. Hydatid disease still, we see a lot of hydatid disease in the country. The mebendazole, it used to be an over-counter, يعني معقمة معاه تأخذه من الصيدلية. الحين صار antibiotic, if it cannot be. So I agree with you, maybe it's not really widely available, لكن this lies in the مجهود وزارة الصحة والCDC والFDA, Saudi FDA, make these available for all those who are in need of it. I'm not aware that a PCR is done without really a trigger, like clinical symptoms or unless if they can wide program for screening before transplant. Sometimes you find these odd things before transplant where they screen for everything. لكن really you have to review the subject and the topic like this to know what is really the infective stage and what is the clinical symptoms and how to diagnose this. And of course in schistosoma or so you may need even to do a biopsy either from the bladder or from the colon to document the disease. And the eradication is very easy on a patient level. And praziquantel single dose is almost curative. Don't rely on the serology. It may last positive for 2 to 5 years. So we don't follow patient by serology usually. That's what I can say unless if أحد عنده زيادة حوراء. دكتور سعاد.
Thank you so much for this nice and kind review. I have a question for the panelists. What do you think the collateral damage / impact of COVID-19 on neglected tropical disease? I was thinking that it was neglected once. Now, after COVID-19, it was neglected for almost few years, then this neglected multiplied by 100. And I don't know if you would agree, and I thank Dr. Mazen, he commented that the study was done in Al-Ahsa in this period, revealed that there is an increase of leishmaniasis quite more than what was before. So it would be nice to share your perspective about this.
Right, yeah, I think two of the studies that we presented was during the COVID-19 lockdown. One was in Al-Ahsa and there was one from Al-Qasim as well. That was one published in Pathogens, the other one in Scientific Reports. Both saw a huge surge of the sandflies, and from my understanding in the paper is that the sandflies were causing kind of a cloud in Al-Ahsa region. I don't know if there's anyone from Al-Ahsa who witnessed it. I wasn't around at the time, thank goodness. Apparently they were starving for proper blood meals because everybody was indoor. So it clearly had a very strong effect on leishmaniasis, and the whole ecology of the sandflies completely changed. And now, as you could see also from the other studies that were presented, in example, the ones from Qasim province, and showed the diversity of the different phlebotomous sandflies, and how the previously undetected type of phlebotomous sergenti, which was more prominent in the western and southern region, were started to appear in central regions like Al-Qasim, and hence seeing cases of Leishmania tropica and Leishmania donovani due to phlebotomous orientalis. So with all the environmental changes that we're seeing, the whole ecology of the sandflies are causing quite a big change in the diversity of Leishmania. Going back to the question of neglected tropical diseases in general, and after the surge of COVID-19, so COVID-19 has a lot of positives from the infectious disease perspective, but unfortunately it also had some negatives, which includes the huge lack of trust of the public in regards to the approach and prevention of infectious diseases. And hence, in the future, it will be quite challenging introducing certain therapeutics, especially with the introduction of new vaccinations and the acceptance of the public. And one of the one of the main elements in the program of the WHO that Professor Abdul Hakim has shown us is that vaccination and mass vaccination plays an important role in eliminating these 21 neglected tropical diseases. However, these diseases are present mostly in areas in which the endemicity is quite high, and this kind of public resistance might not be quite of an issue in certain areas, but might be more of an issue in different geographical areas. So the future will tell, so it might be a hit and miss situation, but we'll always be optimistic, and I'm sure that we will be able to reach this goal in the future.
Dr. Karoli?
Thank you so much for the speaker for the valuable talk. We learned a lot. I have a question to Dr. Mazen, a question to Dr. Hawra as regard to leishmaniasis and Madura. Addressing neglected diseases. For the diagnosis of leishmaniasis, we are facing a difficulty in most of the hospitals. The reagents, the stains, the cultures are not available. This makes it even more difficult to pick up the cases. If you suspect it, they have to arrange for sending the specimen to some other places. So do you advise that we should have it at each and every hospital, especially tertiary hospitals, or we have one center to help in picking up? The second question for you is as regard to the treatment. Which will you go for, for visceral leishmaniasis, the miltefosine or the liposomal ampho? And for the liposomal ampho, our experience, local experience, that we do give it on daily basis. If you look at the literature and the Western experience, they advocate for day 1, 3, 9, and day 6.
Right, yes. Yeah, thank you for the question. So in regards to, especially for cutaneous leishmaniasis, as I presented the data, the sensitivity for both the culture and Giemsa stain is as low as 50 and 30% respectively. So you could miss a lot of cases if you depend only on the culture and and staining, plus the histopathological features. So it is clearly recommended to do PCR, ITS1, PCR, or kinetoplast DNA PCR, or nested PCR is the way to go. And I do understand that these techniques are not really available in most hospitals, but in every region there is a central lab. For example, where we work in Riyadh, the central MOH lab has all these facilities available, so that can be arranged. However, I would the recommendation in regards to the how readily this test should be available in different tertiary care hospitals probably should depend on the number of cases and biopsies that are done specifically for the diagnosis of cutaneous leishmaniasis. If it was a busy dermatology / ID clinic in which they're seeing these cases on a daily basis, then it would be ideal to have such setting within the facility itself, I would understand. Regarding the second part of your question in regards to the treatment, so again, treatment depends on what stage of the disease or how severe the disease is. So most of the time when the lesions are less than 4 centimeters in size or not affecting the face or not above the joints, et cetera, we might not need to treat it. And when we do treat it, local therapy with promomycin seems to suffice. Sometimes you could do cryotherapy, heat therapy, laser therapy, intralesional antimonies, but from what I'm seeing with our dermatologists, they don't tend to do intralesional, and they tend up sending the patients to ID. So systemic therapy is really not indicated for single lesions, but however, if you have multiple lesions, if you have draining lymph nodes, if you have it on the face, if you have more complex disease, then we do give systemic treatment with either antimony or liposomal amphotericin B. And as you mentioned, so the recommended guidelines do say, according to the severity of the disease, to give it on certain number of days, and according to the species as well, they would tell you for the duration. Duration can be as long as 21 days for Leishmania brasilensis, for example. I generally follow the international guidelines rather than just treating it all together.
Thank you, Dr. Mazen. Can we just allow Dr. Hatem to ask the last question? Dr. Karol, please.
شكرا جزيلا بروفيسور والكوليج. شكرا جزيلا. I have a question. We have really struggled with expertise at the lab level. We don't have people who can rely on to diagnosing different tropical diseases. And even us in the medical school and the ID fellowships, local or international, Western, we have limited knowledge into the tropical disease. And this is a big barrier. How can we address this issue in a frank way? Thank you.
This is a very excellent question, very difficult task. والله اللعيبة القدام خسرناهم. We used to have an Indian tech who's now maybe 70 or 80 إذا كان حي الله يعطيه العافية. He was really very expert. Stool examination per se is one of the very difficult bench in the lab. I need an expert because you know the debris are multiple. So without any very well-trained, experienced eye, it will be missed very easily. And nowadays, because of the eradication of most of these neglected diseases from civilized world and from the country, you don't need them, and you don't see them this expert tech. While where the burden of the disease is very high, you have very seldom access to care or healthcare profession or skilled lab. So those people in Africa and India, they are abundant. They are there, but they cannot cope with the magnitude of the issue. So you don't expect anybody will come to your lab. So and the research and the scientific approach to the diagnosis has ceased because it doesn't affect the civilized world. So there is no development of the PCR as a point of care testing or as easy to perform. It has to be a reference lab or a lab like King Faisal Specialist Hospital, where you have a person who is interested in the topic itself. Like as a general population, it's very difficult. Seldomly you'll find people to tackle this. And really, I don't have anything in my head really to resolve this quickly. It needs just a revisit of our curriculum. And even the parasite course was reduced now when احنا بندرس في الكلية الآن. الكوريكولم صار كله صفحتين زي الفقه ولا التوحيد. شايف كيف؟ I don't know how to resolve it. It needs a national. لكن الحمد لله إنه burden of the disease are not hitting us. So أنا أقول حاجة الاختراع. If we are in need, everything will revive again, and you will start to find solution for this.
We should probably encourage some of our new IDs specialists to go into tropical medicine as a subspecialty. We see a lot of people going into immunocompromised, transplant, infection control, but they're neglecting the neglected tropical diseases. For example, I did my diploma in tropical medicine I did it in Liverpool. And it was probably the best teaching experience I've ever had. We would spend hours and hours looking at stool smears, and yeah, it was a very disgusting but educational job. And I could tell you how a strongyloid larva looks like just by looking at it for 2 seconds. And malaria parasites and leishmania parasites, it was a piece of cake, just hours. We probably spent more than 20 hours every week in the microbiology lab. So it was a great experience that I would highly recommend future educators to undergo.
He'll be a pioneer in this. If any idea, he'll be a pioneer. Good.
The discussion is very rich and interesting, exciting, but we are running of time. I'd like to call Dr. Muhammad to recognize the speaker and moderator. دكتور مازن بري. دكتورة حورة البيات. دكتور بدر مهيني. Thank you, Prof. Abdul Hakim, for the rich discussion. Now I will have a break until 13:10, inshallah. The prayer for the male in the second floor, for female in first floor. We'll have the lunch as yesterday. Please, for the speaker and the committee, if we can take a picture here before going to lunch.
Assalamu alaikum, everybody. You are welcome back. We'll start our last session and this conference, which will be followed by the workshops. So this will be last session before the workshops. I hope you will enjoy it and will be beneficial for all of us. Dr. First speaker will be Dr. Muhammad from King Faisal University, Master and PhD from Monash University, Australia. He's the head of Population Health Management Unit, Community Wellness Department, Al-Ahsa, Saudi Arabia. Trainer and lecturer at the Joint Program of Preventive Medicine, Al-Ahsa, supervising multiple research activities conducted by the resident physicians at the Joint Program of Preventive Medicine. Dr. Muhammad, the floor is yours.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين محمد وآله الطيبين الطاهرين وأصحابه المنتجبين. السلام عليكم. I would like to start my presentation by giving my special thanks and gratitude for Al-Musa Health Group and the organizing committee for giving me this opportunity. I'm honored and pleased to be here today in front of you. And we'll start our interesting topic. Have you ever visited a travel clinic? Pre-travel assessment and mitigation strategy. So in our session, we will discuss the travel clinic scope of service, and then we will have a case scenario. We will have a traveler visiting the clinic, and we will be assessing his risk together and giving him general advice and recommendations. And we will provide him also with the specific preventive measures, including vaccinations and prophylactic medicine. First of all, do we have a travel clinic in Al-Ahsa? Yes, we do. We actually have two travel clinics in Al-Ahsa, one in Mubarraz and one in Al-Bandariya. That's in Hufuf, in Al-Bandariya. So the one in Mubarraz, in Al-Faisal PhC, just to remind you, it is not the Faisaliya, it is Al-Faisal PhC, very close to Jarir at Dahran Street, while the one in Al-Bandariya is very close to the King Faisal University. For Al-Faisal PhC, the clinic is operating on Sunday, Wednesday, and Thursdays between 8 to 4 p.m., while Al-Bandariya travel clinic operates on Mondays and Tuesdays between 8 and 4 p.m. Everybody is welcome to visit, whether a citizen or a resident. And preferably you should book an appointment, but it is okay if you walk in and the clinic is not crowded. You will not wait for long. Moving on to the travel clinic scope of service. So the vision of the clinic is that travelers enjoy good health and wellness while traveling outside the country. The mission is to provide high quality preventive health services to all citizens and residents traveling outside the kingdom. So again, I'm emphasizing all citizens and residents. Everybody is welcome at the travel clinic. For the scope of service, first we assess the potential health risk of traveling according to the traveler, the timing of travel, and the destination of travel. And based on that, we help the traveler by providing preventive medical advice, vaccinations if needed, as well as prophylactic medication if needed. In doing so, we follow the guidelines of the Ministry of Health for the general advice in general, while for the destination-specific guidelines, we follow the CDC website, that is the Center for Disease Control and Prevention. We also recommend the travelers to read the healthy travel guidelines provided by the Ministry of Health. Hakuna Matata. Let's have this case scenario, a traveler story who have passed through our clinic. And your homework is to try to identify the meaning of Hakuna Matata in your free time. So we have a traveler, FA. He is a 20-year-old man, a university student living in Al-Ahsa, and he is planning to travel to, can you guess the country? Is it Europe? Is it Asia? It's Africa, definitely, since there are zebras and giraffes, and it is Kenya. He is planning to go to Nairobi, the capital of Kenya. So now, let's assess his risk together. And to do so, we use this form requested by the Ministry of Health, provided by the Ministry of Health, and we need to fill it for every visitor to the clinic. So let's do that together for our traveler. First part, when and where, or where and when. So our traveler, we know that our traveler is going to Nairobi, the capital of Kenya. And for the timing, he's going to go there during the fall season, and he's staying there for 1 week. The purpose of travel is not to work, not study, not to visit friends. It's just for leisure. And during his travel, he will be holding a travel health insurance policy, which is really important. I always advise our travelers, especially if they are accompanied by children or who have some chronic illnesses, to have a health insurance just in case. Now the second part, which is very important, what are the activities that is he planning, our traveler is planning? So he's planning to stay only in Nairobi. He's just visiting Nairobi. He's not going to any other cities in Kenya. For accommodation, he's staying in a 5-star hotel arranged by the traveling agency. He's not planning to climb mountain or hiking. For the animal contact, he's planning to go in a safari. According to what he said, what he mentioned to us, that he's unlikely to be in direct contact with the animal. It's just sitting in a safari, watching the animal from distance. So it seems that he is not at risk of animal bites and so on. In regards to sexual activity, when we asked him, he indicated that he is not planning to have any sexual activity with a known person. And this also important, as we can be sure that he is not at risk of sexually transmitted disease. Moving on to the medical history of the patient. He doesn't have any allergies to food or medication, and he doesn't have any chronic illnesses. This is also important for travelers. For travelers who have chronic illnesses, we would advise them to take enough amount of the medication to cover them during the travel period, as well as some extra just in case. Would advise them to have an extra printed out or written prescription, also just in case they needed to extend their stay there. If the traveler have the risk of loss of consciousness, such as with hypoglycemia or because of epilepsy, would request him to have that indicated in his wallet or wear a bracelet with description of the situation. For our traveler, in regards to the vaccination, he is fully vaccinated with the routine vaccination. He have taken also all the doses of the COVID-19, and he took the flu vaccine, but he took it last year in the last vaccine season. Now we need to ask about the expectation of our patient. What is expectation? What are his concerns? So he mentioned that he read somewhere that people traveling to Kenya should have the yellow fever vaccine, and he wants to know if it is indicated or not. So we will investigate that. When we ask him further about any problems that he faced in previous travel, he didn't had any issues. He didn't complain of jet lag or motion sickness. But most of his travels was around Saudi Arabia and countries close to Saudi Arabia. And this time in his travel to Kenya, we are not expecting him to have jet lag or motion sickness, as Kenya is very close to Saudi Arabia. We asked him further about his ideas of travel precautions. He mentioned that he will use mask in crowded places. He will avoid street food, and he will use hand sanitizer when he cannot wash his hands, which is really good. We need to emphasize that because those are good to practice during travel. Now let's shift our, let's give our traveler some advices, general advice. So we would recommend our traveler to avoid swimming in lakes or rivers. And we were discussing over the last few sessions, today and yesterday as well, about the risk of worms, bilharzia, parasites, insects, and mosquito bites. So by requesting that from our traveler, we will reduce his risk of these factors or insect bites and parasites. We would recommend our traveler to use bus and trains to reduce his risk of accidents compared to cabs. Also, if our traveler gets sick, we would recommend him to go to a tertiary or university hospital, as those hospitals are more likely to follow the guidelines, the updated guidelines. He should avoid sharing body fluids such as saliva, blood, or semen to reduce his risk of acquiring communicable disease. He should also avoid sharing needles, drugs, or devices that can break the skin, such as those used in tattoos, piercing, or acupuncture, again to prevent getting infectious diseases. In regards to preventing respiratory tract infection, in general, he should take the flu vaccine. He should clean his hand often and use hand sanitizer. He should avoid crowded places and wear a mask if he is into such a situation. He should also wear suitable clothes according to the weather. Now for traveler diarrhea, how to prevent it? He should avoid street food as much as possible, as well as undercooked or reheated food. He should carefully wash his fruits and vegetables before consumption, and preferably to peel them if possible. He should avoid drinking tap water or ice or juice made of tap water. He should avoid unpasteurized dairy product. In case he had diarrhea, he should stay well hydrated, and he can visit a doctor to get anti-motility agents such as loperamide, plus or minus antibiotics such as ciprofloxacin and azithromycin. Important topic is the measurement against mosquito and insects. The traveler all travelers are recommended to wear light-colored clothes that are long sleeves. They should apply mosquito repellent such as N-diethyl metatolamide, that is DEET, and they should avoid sleeping outdoor and use bed nets that are sprayed with DEET. And our traveler is planning not to stay outside and to stay in the hotel. Now let's shift our attention to the specific preventive measures. And by specific, I mean specific to the destination. And as I have mentioned earlier, we follow the Center for Disease Control and Prevention recommendations. So it is accessible for everyone. You can do it for yourself when you want to travel, or you can do it for your friends or your family. Just Google CDC, go to, when you have the website, click over Traveler's Health, and then select the country where you want to go. So our traveler is going to Kenya. So let's have the recommendation for Kenya. And this is the website. So for the vaccination and medicine, starting with the routine vaccination, all travelers to Kenya should have the basic vaccination, including chickenpox, diphtheria, tetanus pertussis, flu vaccine, measles, mumps, rubella, and polio. So our traveler is fully vaccinated with the routine vaccines. He's also covered with the COVID-19 vaccination, so he's okay in regards to the COVID-19. But as I mentioned earlier, he took the flu vaccine 1 year back, so we would definitely recommend him to take the flu vaccine. Now, let's shift our attention to cholera. It seems that cholera is active in Kenya. There is active transmission of cholera. So we'd advise our traveler to practice or avoid unsafe water or food. And we would recommend him to take the cholera vaccine. For the hepatitis, and hepatitis A and B, he's well vaccinated with the routine vaccination. But if we had an old person, such as those who are in their 40s or 50s, and we need to make sure that they are vaccinated. If they are not, then we need to take some measures to see if they are immune or not. So let's move our attention now to malaria. So the CDC recommends that travelers to a certain area of Kenya to take prescription for prophylaxis against malaria. So now we need to know, is Nairobi, the capital, is included in the area where malaria is endemic? So what we need to do is to click over the link, country-specific information, to gain more insight. And here we have it. So it seems that Nairobi is also included in the transmission area. What I mean is that it is Nairobi is endemic with malaria, and almost all parts of Kenya. So we need to take precaution. Our traveler should have malaria prophylaxis. But which drug should he have? So here it is mentioned as well that there is drug resistance against chloroquine. So definitely we will not give him the chloroquine. The recommendation is to give him atovaquone, proguanil, doxycycline, mifloquine, tifanoquine. So we'll give him one of those medications. Moving on to see the other recommendations. So for the meningitis, the website, the CDC, recommends that people traveling to specific places in Kenya, that they should take the meningitis vaccine. And those specific areas included in the meningitis belt. So let's see if Nairobi is part of the meningitis belt. So from the website, you can have this lovely map that's where the meningitis belt is shown in the dark color. And it seems that the northern area of Kenya is part of the meningitis belt. Nairobi is toward the southern part of Kenya. So there's low risk, but still the risk is there according to what is shown in the map. So we would recommend our traveler to take the meningitis vaccine as well. Now, in regards to polio, he's well covered, so we'll shift our attention to rabies. For rabies, it is recommended for people that have the risk of getting bitten by dogs or wildlife. So our traveler it seems to be that he has low risk. He's going into safari, but the safari, according to what he mentioned, there is no risk of being close to animal. But we should consider it. We will discuss it with the patient and see if he willing to take it. For the typhoid, it is recommended for travelers that will stay in rural areas or staying with friends or families. Our traveler is staying in a hotel, so he have low risk, but we should consider it as well. Now, for the yellow fever, which is one of the concerns for our traveler, according to the website, according to the CDC, it is not recommended for travelers staying in Nairobi, the capital. So he doesn't have the risk of yellow fever, but again, we should investigate further with our traveler if he is willing to take it or not, just to be in the safe side. To summarize, for our traveler, we would like to give flu vaccine, cholera vaccine, which is oral single dose, malaria prophylaxis. My choice here is doxycycline 100 grams per daily because it's readily available in all the pharmacies in Saudi Arabia. Other malaria medications might not be available. So for the regimen, I will give him to start the medication 2 days before travel and take it daily during his travel. And he should continue taking the medication daily for 28 days after returning. We'll also give him meningitis, meningococcal vaccine, whether subcutaneous or intramuscular, single dose. And we should consider rabies and thyroid and yellow fever if our patient is willing to take. Now, this was a simple case. And before I end this case, I should remind the traveler that if you, based on your returning home, if you feel like anything wrong, if you feel sick or something is out of shape, you need to return to our travel clinic just to assess you. Now, this case was not that complicated. You can imagine if a person have chronic illnesses, or if he is not vaccinated, he doesn't have any records of his vaccination, then things will be more complicated for us in the travel clinic. And also, if the patient was a lady who is pregnant, who need to travel, this also can be a challenge for us. So thank you very much for your good listening, and it was a pleasure.
Thank you, Dr. Muhammad, for this amazing comprehensive presentation. Without further delay, I would like to invite Dr. Saad Al-Mudhri. Dr. Saad, she is from King Abdullah Medical City in Mecca. She is the head of antimicrobial stewardship program in Mecca cluster. She has been graduated from King Abdulaziz University in Jeddah, and then she had advanced education in infection control from McMaster University in Canada. Dr. Saad.
Assalamu alaikum. Good afternoon. Before starting, I want to really say thank you so much for the organizing committee, and it was so impressive being part of this scientific and prestigious meeting. And when I was sitting on the attendees, I learned a lot, and I learned a lot while I was preparing this presentation. So I felt it's a place of exchanging knowledge and exchanging link and knowing such an amazing person from Al-Ahsa, as well as all over the country. So, you know, it's so difficult to speak about travel afternoon, but it's in the same time so good to speak about travel in afternoon time. I don't have any disclosure to start with, but I have, I feel that maybe I should share this. And I want from you, if you know Min Al-Qa'il. I thought that maybe a lot of people would know. سافر تجد عوضا عمن تفارقه وانصب فإن لذيذ العيش في السفر عفوا في النصب إني رأيت وقوف الماء يفسده إن ساح طاب وإن لم يسح لم يطب والشمس لو وقفت في الفلك دائمة لملها الناس من عجم ومن عربي. البقية whose knows من القائل. I don't have any promises for any gift, but I just put it in Al-Musa group. If anyone knows, they may get a free ticket. To Jeddah. Let's make it to Jeddah and Makkah, then I can host him, I can do whatever. Oh, sorry. Al-Shafi'i, yes. So Imam Al-Shafi'i, and he had a lot of, okay. And he had a lot of very nice, I would say, poetry things about travel. And who knows the Shafi'i, he travels for al-ilm, and he's like icons of learning. So let me just start by this slide that it will speak about my talk. As an idea, I thought that I may share how to approach a traveler who came with fever from an ID scope, and it's mostly like tips and tricks in history. Then when fever is the only complaint? Then what if fever came from a transit trip or connection trip? Then little talk about diagnostic tool or orders that we could just reach a diagnosis. Then we don't forget the rule of reporting to infection prevention and public health. Those are my resources that you can scan the barcode and get them ready. I know having them at the beginning or the first slides would just burn everything, but I feel that it would be so nice to know them and to know from where I just speak. Definition of fever is really different. And sometimes maybe I would say, what is the best definition of fever? And someone would ask, what is the ideal definition of fever? Someone would say, what's the real definition of fever? And what's the general definition of fever? Or, if I'm facing someone who is considered as a special host, like immunocompromised transplant, how we will define fever for them? So I feel that what suits the situation to understand the definition of fever, it's what's written in Harrison, Book of Medicine, when he defined fever as a core temperature rectal of 37.5 to 38.3 degrees centigrade, and a skin temperature axillary of more than 37.2, then a morning oral temperature of more than 37.2 degrees centigrade, or late afternoon oral temperature of 37.7. So this is what I could say a definition of fever. One comment before even starting, more indulging and understanding fever in patients who came, or let's say in someone who visited the clinic from traveler. I felt that travel, maybe this is my perspective, and I'm sure everyone has his own perspective about travel. Travel, if I ask you what's the definition of travel, maybe you would say it's a movement. Someone may say it's an exchange. So I felt for myself, travel is an exchange. Exchange of place, exchange of culture, exchange of language, exchange of attitudes, of weather, many things that we could exchange during travel, as well as exchange of diseases. So this is what travel would go. So for that, I felt that every ID physician, or even an internist or GP, should have his own checklist for travel. So this checklist would contain few questions that you may ask someone who came to you and he had a complaint. So Dr. Muhammad, he mentioned a lot of things that maybe look like in pre-travel clinic, and probably we would share the same things even in after traveling. Where did you travel? Precise location/locations. When did you travel? Time. Departure date, return date, exact stay in each destination/destinations, transportation method in each destination/destinations. Did you travel in urban areas, rural areas? What was your purpose of travel? And we know that the trend of travel after COVID-19, as if people was starving to travel, things is changing. It's a kind of funny story. I have an app in my phone called Flight Radar, and at the moment of COVID-19, that one was 0 plane above Kingdom. And this was a kind of nothing will happen again in the history. Then after that,
I just check, like after opening of the travel and promotions that people that could travel, the sky had not even 0.1 millimeter is empty without a plane. So this is definitely change how things could go in travel and tourism. So what was the purpose of travel, tourism, visiting friends or relative, business, or something else was your aim of travel? What special activities did you undertake in travel? Hiking, scuba diving, cave exploration, dental or medical care, newly acquired tattoos, or others. Completing the list, did you experience any specific risk exposure? Sexual risk, how many partners are there a protected type of sex behavior or attitude, type of sexual exposure, consumption of poor quality water or food, ticks or other insects bite, swim in lakes, contact with wildlife. Accommodation in every place, living arrangements, dwelling type, use of mosquito nets, air conditionings, window screens, exposure to sick individuals, or knowing there is any fellows traveler with you was having the same symptoms. What vaccination did you receive before in the travel clinic? Where did you take the malaria prophylaxis? If so, which drug did you take? When did you start it? And did you take it regularly as directed? Are you still taking it? And also one important question, did you become ill while you are away? Did anyone accompanying you became ill? So those are checklists that it should be in post-travel clinic if someone consulting you for someone who came from travel and he had symptoms. When we travel, we expose to other human beings and we expose to environments. So this is just a few examples about things that carry risk and we expose to them. Reviewing some of those risk factors, exposure to undercooked food. This would make our patients at risk of cholera, non-typhoidal salmonellosis, trichinosis, typhoid fever. Untreated water, cholera, hepatitis A, non-typhoidal salmonellosis, and typhoid fever. Unpasteurized dairy products, Brucella and TB, sometimes, I would say. Freshwater contact, leptospirosis, schistosomiasis, and others. Sexual contact, all the STDs plus immunodeficiency virus. Animals contact, definitely he will be at risk of Brucella, Blake, Q fever, rabies, tularemias. Insects, mosquitoes, definitely he will be at risk of malaria and dengue fever, ticks, rickettsiella disease, tularemia, and tsetse fly, African trypanosomiasis, sick contacts, meningococcal disease, TB, viral, and hemorrhagic fevers. So those are the first step. Probably we're going to do them when we see a traveler in our clinic who was referred to us because of fever or it was a part of consult. One of the most important things that it's really a key point is the incubation period. And defining incubation periods is from the time of exposure until having the symptoms. And it would be easy if we list as less than 21 days and more than 21 days. And sometimes you might find it in few resources, less than 10 days, between 10 days and 21 days, then more than 21 days. And this is probably the differential diagnosis that should come in mind when it goes in neither nor, less than or more than 21. Physical exam is the second step after having the checklist of history when we have a patient. So definitely a proper examination would lead to increase the ability to diagnose the patients. As an ID, we really obsessed, I should say it this way, we are really obsessed about history and exam. I remembered when I was trained and my mentees and my mentor who was trained me, he's sitting in front of me now, and every time I was feeling so shy because he came and he asked a patient a question that I don't ask. Then I realized what's the meaning of history. And we have a WhatsApp group, me and our fellows group, and every time they joke, they send, go and take history more. Go and do an exam. So I do believe that history and exam, 100% will give a provisional diagnosis or ID working diagnosis or even the ID precise diagnosis. So vitals, as usual, is one of the important things to do. Pulse and temperature dissociation, and this is common in what infections attendees? Yes, typhoids, and what else? Anything else? Despite it's not common, but this is the commonest, definitely. Sometimes in brucella, but typhoid is the commonest. Then rash, maculopapular rash, as in viral diseases, measles, rosa spot as in salmonella, eschar and as in all, probably rickettsial disease, petechiae, ecchymosis, or hemorrhage, legion as in hemorrhagic diseases, examining eye of the patients for conjunctivitis, examining sinuses, ears, and teeth. One thing is just to highlight that not every traveler who came with fever, this would mean a fever related to his travel. There is occult infections that came and presented just after travel and has no relation to the travel. Then examining the heart and lung and abdomen, lymph nodes, and CNS exam. Common clinical findings that sometimes may guide us to a specific diagnosis in returner traveler with fever. So if this fever accompanied with rash, we will put in our differential dengue, chikungunya, Zika, spotted fever, or typhus group, rickettsiella, typhoid fever, scalegion, may spread by absence, acute retroviral disease, measles, viruses, mononucleosis, parvovirus, and the list go on. So just try to have your own approach and going combining symptoms if it's there. Fever and abdominal pain, typhoid fever as an example, or amoebic liver abscesses, and differential fever and normal or low white blood cell counts can go with dengue, rickettsial infections, and typhoid fever, chikungunya, Zika. Fever and hemorrhage, you may think in viral hemorrhagic fever. Fever and eosinophilia, you may think, and all the parasitic disease and acute schistosomiasis is the commonest, definitely, plus drug hypersensitivity reaction. If these patients receive prophylaxis and it's just a kind of late drug hypersensitivity reaction. Fever and respiratory symptoms, you could just put all the respiratory viral illnesses and definitely from others like acute schistosomiasis, Q fever, leptospirosis, pneumonic plague, and tularemia, plus MERS-CoV. Fever and altered mental status, malaria is one of the things that it should be at the top of the list. Meningococcal meningitis and bacterial meningococcal encephalitis, East African trypanosomiasis, and sometimes rabies. If the patient came with mononucleosis syndrome, ABVs, 1 CMV, and acute retroviral disease, fever persisted more than 2 weeks or more than 6 weeks, definitely we reviewed in the previous table, and you could find this easily in the CDC guideline or travel yellow book. Special host traveler, it's not the place to speak about them because I may spend all the afternoon time speaking about special host, but we should consider how important is our patients when they visit us with fever and they are immunocompromised, post-transplants, sickle cell anemia even be considered as a special host. This is an important consideration that we should have an idea about it. Connection trip in Africa. So I think Dr. Mohammed, he bought a map of someone who visited Kenya, and I bought a map of someone who had a luxury in Africa and visited everywhere. So Mr. J, he is a friend of my friend, who is a 40 years old, an engineer who work in Neum, in constructions and building things in Neum city, and he decided to spend his summer vacation in Africa. He thought that a multiple city trip is the best to enjoy. He took his trip from Jeddah airport to Cairo. He spent almost 2 days in Cairo. And he said that he visited a dam water. He eat fisikh. So if you know fisikh in Cairo. And then he took a trip from Cairo to Addis Ababa, as seen in the map. In Addis Ababa, he stayed 2 days. Then from Addis Ababa to Tanzania, he spent most of his time in Tanzania. In Tanzania, he climbed the Kilimanjaro mountain, or Jabal al-Qamar. Then he said he didn't complete the climbings of the mountains. He had what called, I don't know, it's called Da al-Jibal, da al-mountain. I don't know, it's not sickness, it's something, it has an abbreviation, hyperbaric something. I don't remember it exactly, but I reviewed it at that time. Then he stayed in Tanzania. He enjoyed a kind of Tanzanian dance called Kongaru. He ate a Tanzanian food. He learned some of Swahili language. And he decided to leave Tanzania to Botswana through a safari and land border of Zimbabwe. So he crossed the space from Tanzania to Botswana through a land traveling, through borders. Then finally, he enjoyed his stay in Cape Town for 2 weeks. In Cape Town, he tried marijuana. He had encountered sex with beautiful ladies there. He drank. He swam with a white shark, and he came back to Neum again to work, and he visited his physician after coming back when he had a fever by 7 days. He said that he didn't have a time to visit a travel clinic, but he consulted someone through a phone. Then he told him, at least take the yellow fever vaccine. So when I get the call as a consultation for me to just bob up and said what it could be a differential diagnosis, I said, okay. From where I should start? That, as an Egyptian people may say, أكلك منين يا بطة. So from where I should start, really? I mean, he had all the risk of all the diseases that I imagine, and I don't imagine even though. So then I started to speak Swahili because I don't know how to diagnose this guy. So this is just imagining how it would be a consult in travel clinic, or let's say if we were involved in such cases. And again, travel checklist is one of the things that I felt it's nice to create because it will help us understand more about the nature of travel. Geographical area, because as I said, travel is exchange. So there is clear a nice table in CDC explaining the risk of people. So there is a risk from tropical diseases, and there is another risk from what we call outbreak clusters that sometimes can happen among travelers. So Caribbean travels, chikungunya, dengue, malaria, and Zika as a common diseases as a tropical. And there is outbreak that can happen in traveler like histoplasmosis and acute leptospirosis. Central America, chikungunya, dengue, malaria, and typhoid plus paratyphoid fever, Zika. The cluster things that can happen to travelers, coccidomycosis, histo, and leishmaniasis, leptospirosis. South America, chikungunya, dengue, malaria, Zika, and the outbreak stuff, which is Bartonella, histoplasma, lepto, and yellow fever. South Central Asia, dengue, malaria, typhoid, and fever. So we could see malaria everywhere. So just prophylax people and just, thinking at prophylax, and this would be, I think, kinds of safe approach to the people. But the difficulty is which one and for how long, and if the patient would take it. Then, and this, I would say Southeast Asia is dengue, malaria again. Sub-Saharan African dengue, malaria, tick-borne rickettsiella, and schistosomiasis. And again, you could find those tables in the CDC Yellow Book. Diagnostic test, and I feel that it's maybe we should say diagnosis, because it will be sometimes not helpful, and you may come back half al-qadamain. At the end you would be not able to diagnose the patients because it's a kind of difficult lack of challenges and lack of facilities and all this stuff. So basic lab test is an important to show us the leukocytosis, to show us eosinophilias and all those things that can help us. Blood cultures, and even there is a debate to do blood cultures in cases of someone who came from travel and he came fever. Despite that, I don't personally, I'm with the side of debate that I should do it. Blood film, peripheral blood films, stool sample, urine if it's indicated, and CSF sample again if it is indicated.
5 minutes.
Okay. Respiratory samples, and we could just see if the patient had respiratory symptoms, X-rays, and rapid diagnostic test that it may help us Sometimes we could use antigen antibody in certain diseases, and it could help us in diagnosis. Examples: dengue, retroviral disease, definitely it may help. Ebola antigen, if it's available in the hospital. Influenza, malaria, sometimes nucleic acid PCR, if it's available. Chlamydia and respiratory panel, sometimes Neisseria and SARS-CoV. If it is available, it may give us rapid results, and it may help us in diagnosis. Febrile syndrome that sometimes came as fever in returnal travelers, not only with fever, so we could just correlate what it could be with. If the patient had fever and jaundice, we may think in hep A. If he had a flaccid paralysis, we may think in polio. If he had diarrhea, cholera. If there is decrease in level of consciousness, meningitis, it should be there at the top of the list. And this would be a kind of warning signs and rapid actions that it could be taken. If there is a cough, pertussis sometimes, according to the location and geographical mapping. And if he had hemorrhagic symptoms, viral hemorrhagic fever. If he had rapid respiratory rate, we think in acute viruses that may have, and all the outbreaks that can happen. If he had rash, measles, meningococcal, and viral hemorrhagic fever, vomitings, we may think in norovirus. Take-home lessons. So take-home lessons that I felt that I could share with you as a learning points. Febrile illness is common, presenting feature in returner travelers, and requires a clinical and epidemiological risk assessments. A complete history and physical exam together is the key. With initial lab investigation may give us a clue to diagnose a tropical disease, and estimate definitely of an incubation periods may narrow definitely our differential diagnosis. Fever in returner travelers require an urgent interventions to exclude malaria and preventable death. Resistance may be required in the lab diagnosis of malaria, as the panelists were today morning saying, oh, I cannot exclude it, I should repeat and repeat again. There is an increased concern to consider emerging infectious disease and disease to public health importance. And I felt that as an ID, the major rule that we could report to the public health and be part of success of reporting the reportable diseases. And this would help in creating a plan to eliminate those probably diseases and have enjoy travels for the people. With this, I end my presentation, and thank you so much.
Thank you, Dr. Saad, for very comprehensive and informative presentation. Now let's invite Dr. Muhammad and Dr. Saad for the discussion and taking few questions. Any questions to Dr. Saad or Dr. Muhammad? Any questions? Yes, Doctor.
Assalamu alaikum. My question is for Dr. Muhammad. Thank you for the nice topic. My question is, what is the scope of service for a travel clinic? Is it only for counseling, or there is management scope?
Our focus on prevention mainly. If the patient have some chronic illnesses that's easy to manage, I mean, prescribed medicine, he's taking just one medicine. It's totally okay for us to provide him with all what he's needing during his travel. But if his case is complicated, he's taking multi-medicines, we would advise the patient to go to the team-based care and discuss his travel plan with them, so that he have the management from the main source rather from the travel clinic.
Yeah, the reason why, because we have faced, like in the emergency department, we face some of the patients coming from travel, bitten or scratched by some animals, and they came to the emergency. I think those such patients, they need like some follow-up for vaccination, for immunoglobulin, I think we can decrease the burden in the emergency department if we can like send those patients for follow-up in the travel clinics.
Yeah, I do agree with you. Like anything related to travel should, like the patient's returning from his travel and he have some issues, a disease he get from his travel should be managed in the travel clinic as much as possible.
Thank you.
Mm-hmm.
Question? Okay, if there is no questions, I have a question to Dr. Suad. What you have done with Mr. J?
I think I said I speak Swahili, that's it at the end. I recommend him to visit one of the travel clinic, and because he's not immunocompromised, he was healthy. I don't have any idea about his vaccines previously. So I was thinking that maybe the things is just malaria, but he ended by having dengue, and this is, alhamdulillah, likely good things. But it was like sitting and listening to the story was for me a kind of, oh, what things that you didn't do. So he was seeing someone else, and at the end he was diagnosed with dengue, and he was doing well. But the lesson that I learned, that as much as travel is think of enjoyments and exciting things, again, I don't know, maybe it's just be me, like an ID, I like obsessed even with everything. So egg, I will not eat. Corn, maybe. Let me just think and what that. Water, it has an ice inside. It's tap water. So I think being meticulous in what we expose to in foreigner country is an important thing. It's not something that to take it lightly. It's something to concern, because we want to have enjoyable travel and we want to stay safe, and even back we want to stay without fever, definitely. Yeah.
Thank you, Dr. I think it is tough. This scenario is very tough. Some patients may need follow-up because some HIV cases they present like just flu, and they need follow-up. They might be in a window period, and they need follow-up to get diagnosis of these such cases. It is very tough. Thank you, Dr. Saad. Dr. Muhammad, in your clinic, when you advise for a vaccine, are you giving it in the same clinic, or you advise that they take only advice and they will take it in health centers? Or
No, in the same PHC, we have the vaccination unit. So we just refer our patients to the vaccination clinic, and all of the vaccines related to travel, other than the routine vaccines, are available in the clinic.
Thank you, Dr. Muhammad. Dr. Saad, I don't know if there is any questions.
Thank you very much, Dr. Muhammad, Dr. Saad. I just have one concern, how you evaluate the public awareness about travel clinic. Now in Al-Ahsa Specialist Hospital, we have travel clinic in collaboration with family medicine. It is there, the vaccine is there, but still there is barrier with the community in coming to travel clinic. So how we can improve this?
Currently, we are working with one of our colleagues, the Department of Health Promotion in the Community Wellness Department, to raise the awareness in the community about the travel clinic. So with every campaign they do, there is one boat that announced that we have a travel clinic, you are welcome to visit it, we can provide vaccination, consultations, and but I believe we need to market for it more and more. Mm-hmm.
So from what we have in COVID experience, do you think the mandatory restriction on the travel requirement would add to this, I mean, like mandatory education? I mean, to make it a restriction, to make it mandatory for the travel, like a visa.
From my point of view, as I like travel, I wouldn't have restriction. And I believe like people are traveling because they want to experience some freedom. So I'm against it, just raise their awareness regarding the travel clinic and the services and how they can benefit from it rather than to put more restriction. What do you think, Doctor?
I would say the same thing. I think awareness is so important, and probably all of us, we noticed that in latest 7 years probably, the travel work in Saudi was changing. We don't know previously, maybe before 7 years, what's travel clinic, and no one knows. But nowadays there is a document from Saudi CDC, Wizard Saha. It has all the travel clinic in all the areas of Saudi Arabia, with even link that you could just click on it, then it would give you the Google map, where is the clinic exactly, and the working hours. And also there is in the Twitter for the Ministry of Health, the travel clinic, their hashtag is لنسافر بأمان. So they just go for it, and the direct call to 937 to consult what kinds of vaccine I could say taking. So I felt that awareness is one of the important things for people to get. One thing more that I find it so interesting, in the website of the Saudi Airlines, there is clear icons about travel. So when you are coming to Saudi as Hajj and Umrah, you should take. And when you are traveling or visiting Saudi as a transit trip, those are requirements in the transit trip. There is clear, nicely written documents that is in Saudi Airlines website. And I think also another parts of Hajj and Umrah document that it was updated in 2024, even this year. It has a lot of recommendation for Hajj and Umrah when they're coming to Saudi. But again, awareness is one of the cornerstone that I think would just give a reflection and increase awareness of the people.
I think to give time for workshop, we will conclude here. Thank you very much, Dr. Suad and Dr. Muhammad, for this amazing presentation and discussion.
So now it's the time for recognition of the speaker and moderators, and also we will recognize the speaker of the workshops. So I will ask Dr. Zainab Al-Musa for recognition of the speaker and moderator. تفضلي دكتور. دكتور محمد الرمضان. دكتورة سعاد المذري. دكتور عبد الله باردوان. دكتور ياسر الدباغ. Now the recognition of the speaker of the workshop, Dr. Fatima Shahrani. دكتور حيدر غزال. دكتور فاضل جبر. دكتور عباس المطير. Thank you, Dr. Zainab. No, for the workshop of TB and hemorrhagic fever will be in this hall. The two workshops for research and for the microbiology will be in the second floor in the hotel, inshallah. And there will be a bus with tour for the rehabilitation hospital for the VIB guest and for the scientific committee. The bus, inshallah, will be on the registration door. It's ready. The tour will start now for those not interested or those who are interested to attend the workshop, they can stay. Those who want to go for the tour, the bus is ready now. Thank you.
Sir, please. Assalamu alaikum wa rahmatullahi wa barakatuh. Happy joining you today, and thank you, Dr. Zainab and the scientific committee and the organizing committee. Thank you, Dr. Muhammad, for the invitation. I will talk about hemorrhagic fever, what the infection preventionists should know. Actually, it was a long presentation, but after what we attended already, and all the experts already present a lot of details in this regard. So I was asking myself, what should I add after Dr. Muayyad, Dr. Thaqafi, and Dr. Al-Hazmi, and others? They talked about it all. So I will present a case. It's a real case. Yeah. So the content is a case scenario, and we will talk about the precaution measures and the differential diagnosis, and after that, a short overview of hemorrhagic fever and some MCQs for entertainment. This is a real case. He's a 33-year-old man. He is a Sudani guy. He was brought by ambulance from a private sector to our hospital, accepted for emergency situation management. Actually, he had a history of 1 week undocumented fever. Then it was documented in the private hospital, ranging from 38 to 39 Celsius. And he was having hemoptysis and hematochezia and also hematuria. And he had skin lesions all over his body, more in the palms and of the hands and the sole of the feet. And he had a history of fainting episodes, and he's not as active as before. And he was having also mild epigastric pain, and he noticed also that he's having unintentional weight loss and loss of appetite. He has an on and off headache preceding all these symptoms. And he had also an on and off back pain. He worked as a farmer, and he don't recall any insect bite, and he didn't notice that he was having any bats or rodents around his environment. He denied history of nausea, vomiting, chest pain, shortness of breath, neurological symptoms, and he has no chronic illness, and he has no previous admissions, and no blood transfusion or surgeries before, and he cannot recall his vaccination history. He's not taking any medications. He's a single man, and he denies any sexual history, and he don't have any contact with any person with similar symptoms. And about his travel, he was in Sudan 3 months before these symptoms. He came to work in Saudi Arabia. He visited Mecca for Umrah 3 weeks before this visit to our hospital. And and also he has a friend who came to visit him 2 weeks ago, and that friend was from Uganda. On examination, he was conscious, alert-oriented, and his vital signs, he was febrile, he was pale, and he has no jaundice and no clumping in his nails, his palms and soles, so he was showing hemorrhagic nodules, which was shown in the first slide. He has no lymph nodes detected in the examination. Other than this, he has a mild knee swelling. It was noticed during the diagnosis and with normal range of movement. His platelet was 7, and he was having hypochromic microcytic anemia. Hemoglobin was 6. White cells was normal. He was having elevated liver enzymes, mild to moderate increase. His LDH was 599. His creatinine renal function normal. He was having hypovolemic hyponatremia. It was mild. And his fibrinogen was normal. Labs sent for hepatitis and HIV, and also for brucella culture, and malaria smear also sent. His procal was 0.2, and CRP was 9, and his urine showed frank hematuria with more than 1,000 RBC. So the differential diagnosis was broad. Given that he's a farmer, we have a clue that it can be brucella. Other diagnoses we cannot neglect or keep it down, which is the dengue, malaria, bilharzia, schistosomiasis, and also the al-Humra also disease and others, since he was in Mecca and Jeddah. Also, the IC was on the differential diagnosis when he was seen in the ER, TTP, and also ITP. So consults for the general medicine, infectious disease, infection control, and hematology done the first day of admission to the emergency. He was given platelets and RBCs. Ebola was suspected based on his friend visit. He's from Uganda, and that time, you know, the situation globally was there was a high alert for Ebola. Although he denied any history of, his friend doesn't have any symptoms and he has no contact with any sick person. So this patient was under maximum isolation measures, and people were asking, is it Ebola? Is it something else? So we just say, put the patient on maximum precautions. And at that time, it was like, we are lucky because we were thinking about doing a drill for Ebola. And he was our real drill. So I said, okay, keep Ebola in the list of the differential, put him as an Ebola query suspected case, we consulted Public Health Authority, MOH, and we sent to them the notification, and they helped us through the national lab to do all the labs requested and needed at that time. So we asked the team to keep the maximum measures and also to limit the exposure and list all the contacts and list the time spent with the patient with the PPE details, what was used when they came and to see the patient. Day after day, his platelet was not improving in the first 3 days. It was still low after even 5 units of pooled platelets. His blood film showed unremarkable morphology with few reactive lymphocytes and marked thrombocytopenia. Malaria smear was negative, and he was given DEXA for suspicion of ITP. His virology screening negative for hepatitis and HIV, and the stool and blood culture came out negative. On day 4, we have positive brucella culture, luckily, and he was started on treatment. His platelets started to pick up, and he was having knee involvement, طبعاً. From the first 2 days, we thought even about HLH, which is not really, because his fibrinogen was not low and triglyceride was not high. So, messages from this case. As infection preventionist, all of us should be infection preventionists, even from ER. We need to take all precautions. Don't wait for infection control to give you the clue or to do whatever you want to do. Do your maximum precautions. It's not wrong to start at maximum and then you downgrade the precautions. Don't wait for a confirmatory test to say this is Ebola or this is brucella or whatever. Always go for the epidemiological link and the travel history. Do not hesitate to consult if you need any help from your colleagues. And you take all the precaution that is needed. And make also close follow-up for the contacts. Restrain the healthcare workers from their work if needed. And all of these things should be communicated with the hospital administration and the Public Health Authority and MOH from day 1, from minute 1 even. This is the message. It can be viral hemorrhagic, such cases. It can be also malaria, typhoid, meningococcemia can also present with the same presentation. All of these diseases were already discussed in details yesterday. Keep in mind the incubation period, which is usually from 2 days to 3 weeks maximum for the hemorrhagic fever viruses. The samples should be taken care of carefully, not like any other samples, because it needs to be shipped to the national lab and they will deal with it. So you need to do triple packing, and it should be leak-proof container. And all these precautions, you can take it through the hemorrhagic fever guidelines in the Wiqaya website. Donning, doffing of PPEs. You will see it at the door of the rooms. You just go into the sequence and read it in details. Common mistakes that we see when people are using PPEs. For example, a nurse who will take off her PPEs, she will do the doffing and she will leave without cleaning the hands and start doing her other routine activities. This is totally wrong. We need to clean the hands after doffing. Gloves alone is not any, but we need to make the hand hygiene. Also, some people, they will touch the phone during their visit to the patient in the room. They will touch the phone, they will, with the gloves, so this is not appropriate. Also, some people will touch the face with the gloves, gloved hand or hands which is just taken off the gloves without cleaning. This all are mistakes during the PPE use. Waste management, I think most of the institutions are doing training for the housekeepers, and they shouldn't be neglected part of training and education, because they can cause a lot of problems if they will not be aware how to deal with the situation, how to deal with the wastes. Also the laundry personnels. Now we'll go for the MCQs. I know this is the last session and you're already feeling tired. I have only simple 5 questions, and there is gifts as per Dr. Mohammed. I didn't see anything yet. How can the morphology of filovirus be described? Very large, ball-like structure? Okay. Can you scan it, please? طيب مين اللي يفوز في الأخير؟ كيف تختاروا الفائز؟ هذول يعني جاوبوا صح؟ خلاص؟ طيب. Okay. خلاص طلعت. Okay, who's Anisa? Congratulations. She's the only one. طيب. So the viruses of this family can be 1,400 nanometer in length, and once seen under the electron microscope, it will be never forgotten. طيب, last and Ebola emergent viruses in West Africa. What is their origin? Human pyramids, fruit bats, and pigs. Should they do the scan again? نروح الإجابة على طول. Are you done? خلاص؟ شكله ما في جواز اليوم. طيب, the answer is fruit bats. طيب, ما حد جاوب. طيب خلاص, يلا. لسه في فرصة, لسه في 3 4 5. How can the spread of filovirus be restricted? New antivirals or new monoclonal antibodies, ولا hygiene and social distancing, ولا new vaccines? في مشكلة في السيستم؟ Anybody was able to put the answers? في أحد جاوب؟ خلاص؟ نكمل. وداد؟ مذاكرة كويس. طيب. What What's the biggest risk factor for infection with Ebola? Working with a category 4 lab, attending funeral of a victim outside, nursing a patient at home, attending football match or large gathering. الكنترول عند مين؟ عندك؟ أنا ما سويت شيء. Nursing a patient at home. جواهر. If he's nursing his patient with the full PPE, he will not have any risk. طيب, which lab finding is commonly seen in patients with hemorrhagic fever? High hemoglobin, low liver enzymes, prolonged PT, and PTT, normal platelets count. This is a gift. خلصنا؟ جواهر. وداد. زهرة. وداد خلاص already. يلا شكرا لك.
دكتور ياسر ما تغشش مصطفى، ممنوع. في جوائز، استريح. بس شغل الكاميرا عشان تعمل كود. يلا نبدأ. إبراهيم. Bismillah ar-Rahman ar-Rahim. So we will start our competition in this workshop. As Dr. Fatma mentioned, we will just make it interactive and simple. We are at the end of the day. But mycobacterial tuberculosis, 80-year-old man brought to emergency room by his son. This is a real scenario actually. With a history of fever, night sweating, fever for 3 weeks. Evaluated and admitted under airborne infection, isolation, and negative pressure room as a case of suspected active pulmonary tuberculosis. Now, all of the following are factors that increase the likelihood of TB transmission except, so the question except, first, sputum is positive by smear microscopy. Patients who have lung cavities observed in the chest radiograph, those who are undertreated and showing response, sociability of the index patient, like a teacher or signal. Everybody follow? Okay. So 13. نداء ممتاز تفضل. So the idea here that it is accept. So all of these factors increase the risk for patient to be more infectious. Except those who are showing response in treatment, actually it's the opposite. They are expected to be less infectious. And this is one of the criteria, as my colleagues mentioned in the TB session, that for discontinuation of isolation. So this is the answer. So infectiousness related to the number of the TB particle that expel per air. This is why TB patients generally give more tubercle bacilli during coughing, or they produce a lot of sputum. Now, those TB patients with lungs, airway, and larynx, they are very infectious. So laryngeal TB, active pulmonary TB, they are the one who really very infectious and need to be isolated in negative pressure room. So now there is some factors mentioned in the question, some not mentioned, like presence of cough, cavity, the acid-fast bacilli that is positive smear, because there is still active TB with negative smear and positive, for example, molecular. They are less infectious, but they are still active TB. TB of the lung, larynx, as we mentioned, not covering the mouth or taking the precaution, not receive adequate therapy or prolonged illness history. Those who are getting a procedure like bronchoscopy or induced sputum is another risk factor, and of course positive cultures. Now, infectiousness show that it decline upon treatment and declines over time from weeks to months. Now, patients with a drug-resistant TB might not respond to initial therapy, and they might be infectious longer than usual. And this is what we talk about, the isolation and precaution. Now, in children, it's a bit different from adults, are less likely than adults to be infectious, but still, children generally don't give or don't produce a lot of sputum, and they sometimes take a gastric sample, but still young children can be a risk factor for transmission of TB if they have pulmonary TB. So the next question, can you scan and get ready before we read the question? It should appear. So now the same patient, the same one that be admitted, diagnosed already as active pulmonary TB and started on a treatment. Now, after 4 days of hospitalization, boom, he has acute abdomen. Seen by the surgical team, and the surgeon wants CT scan for the abdomen. Now, the plan should be include all of the following except, first, place a surgical mask on a patient and observe respiratory hygiene and cough etiquette. The transporter should wear a surgical mask. Now, if the patient cannot tolerate wearing a surgical mask during the transportation, the healthcare worker should wear double surgical mask. The receiving unit should be informed about the infectious status of the patient to apply necessary precaution. Now choose. Common scenario for admitted patient, TB patient. Okay, 13 already. خلاص. في فرصة. So, who was the pastor? Dr. Muhammad. You are biased, Dr. Muhammad. Dr. Muhammad presented the TB session. So yes. So this is related to transporting TB patient in the healthcare facility. So nothing called double masking. So an airborne precaution during the transferring of the TB patient, you ask the patient to wear a surgical mask and the healthcare provider. Now, if the patient refuses to wear a surgical mask, you ask the healthcare provider to put N95 during the transport. Of course, you should notify the area that you transfer the patient, so they will take the precaution. They will prepare the N95 or the surgical mask of the patient. They might include some preparation of the room, especially if he is going for a procedure, and to make it at the end of the day, usually when you transfer the patient of TB for doing radiology procedure. So get ready for the next question. The CT result, unfortunately, unlucky wallah, appendicitis. And he require emergent surgery. Patient of active TB getting appendicitis and should go for surgery. No, you should do all except schedule it at the end of the operation list, if possible. Try to change the ventilation parameters of the theater. A portable HEPA filter should be used during intubation and extubation and should be off during the surgery. If possible, post-operation recovery should be in negative pressure room or at least single room with portable HEPA filter. The infection control team should know all of this information, because this is a real scenario. You could have it with TB patient in the healthcare facility. Oh, 16 already? Dr. Muhammad already, but we will not give him. We give the second. So Iman, our infection control practitioner. Excellent, Iman. احنا اللي فاز مرة نعطي اللي بعده. So yes. So the idea here, you should be ready for operating TB patients from administrative, environmental, and respiratory protection control program in your hospital. So as much as you can, postpone non-urgent procedure for suspected or confirmed TB. No, there is urgent procedure that is different, like in our case, but at least if you can, to do it at the end of your list. Do procedure at the end of the day, avoid traffics in the OR unless required. Now, the environmental, if clinically possible, the patient should be intubated in negative pressure room, then transferred to the theater. This is not practical, I can't tell you, to have a negative pressure room just for intubation, but maybe some healthcare facility they have. The problem with TB patient in the OR, that the OR you need to have positive pressure room for surgical site infection. At the same time, you need to put a TB patient in negative pressure room. So how to solve this dilemma? That is the recommendation from the CDC and our national Saudi guidelines. Now, if possible, post-operative recovery should be in negative pressure isolation room or at least single room with portable HEPA filter. Now, the surgical team must wear N95, not to wear any mask with valve. So it should be valveless mask. Never try, never, to change the ventilation parameter of the theater. You don't need to put the theater in negative pressure room. Next. هذا البريفيوس أنا رحت. So that's the one. Yeah. Okay. So get ready for this question. All of the following should fulfill before removing airborne precaution. قلتها من شوي. Produce a 3 consecutive negative sputum smear collected 8 to 24-hour interval. One should be early morning. Receive at least 2 weeks of standard multi-drug anti-TB treatment. Chest X-ray back to normal. Show clinical improvement. So be careful. This is accept question. لا تغششهم. تغششهم غلط مشكلة بعد. Okay. Okay. أنا غلطان اللي خليتك تشارك. No, إيمان ومحمد, we will not give. مسراء. Excellent. الله يعطيك العافية. So, chest X-ray and TB and pneumonia in general need time, so don't expect the chest X-ray to be changed before 4, 6 weeks, maybe sometimes months. But all of the others are a criteria of discontinuing of isolation, as we mentioned before. We are still talking, Victoria? Which one? No, but still, the one who, not for each question, but we have different votes at the same time. But the one who, for example, take the third, he is not the faster? طيب كيف نعرف الحين اللي جاوب أسرع؟ زين. ما أدري أنت أنا قلت لك ضبطها. طيب. The same patient. ما رحنا بعيد. In the previous case, discharge home on anti-TB. After 1 month, presented to the emergency room with fever and hemoptysis. What do you want to do? Isolate, assess compliance, MDR-TB risk factors assessment, reassure, outpatient follow-up, ما في كل العافية. Admit to regular ward and start antibiotic, tazocin. Send to the ID clinic to assess compliance and let the ID physician see him in the clinic and assess him for MDR-TB risk. What do you want to do? زينب في معانا زينب كيف طلع اسمها وهي مش موجودة؟ ها؟ مين زينب؟ ها؟ هي كيف طلع اسمها وهي ما صوتت؟ ها؟ لا ما البقية كلهم أخذوا. أعطي اللي بدك إياه خلاص. So the idea here that this case could have multi-drug resistant TB. So don't take it lightly. Because acknowledging TB patient to take treatment is really tough. Need proper counseling, need sitting with the patient. Cannot do it by phone or just by one single visit. Because it's associated with a prolonged treatment, it need many pills, common side effect. So risk factor for drug-resistant TB always should be assessed, especially in a prior non-dot-based MOH follow-up therapy. In a patient non-compliance, an incomplete therapy or lack of documented therapy, non-CDC, non-WHO guidelines following, or at least national guidelines in that country for the regime. Risk factor also related to contact with multi-drug resistant TB in countries that is known, that mentioned in the slides today or yesterday about multi-drug resistant TB in Dr. Rajhi lecture. Lack of response to therapy, progression of the radiological feature, not improvement or resolution at all, but at least there is a progression. MTB culture is still positive about more than 3 months, which is unexpected. So you expect the culture to be negative by 8 weeks, usually or less. International TB endemic regions, overuse of a fluoroquinolone antibiotics in that community, delay in the diagnosis, and inappropriate antibiotic exposure like a quinolone. Maybe this is the last question. Get ready. فقط الموجودين يصوتوا ها ما نبغى اسم مو موجود. هو اذا مر الطريقه اللي انت عملتها شكلها يعني كل صارت كانها سحب بالحظ ترى. الله يعطيك العافيه ما في مشكله ما في مشكله. حتى لو هي بالحظ يعني ما ادري. بس بدينا كويس في البدايه. يلا. Now the brother of the patient is 45 years old man with systemic lupus erythematosus on immunosuppressive therapy. He's in steroid, he is in cyclophosphamide, and he's worrying that his brother has TB. He come to your clinic and ask you what to do. So, you will send him to the ER, isolate, and start anti-TB. خلاص. Admission. Or, if no symptoms and signs of active TB, reassure. ما فيك إلا العافية. If no symptoms and signs, screen him for latent TB. Ask him, stop immunosuppressive and screen for latent TB. You don't need steroid because you might have reactivation of TB. Stop it. No need to call anybody. I know everything. 13, 15. So the contacts of the patient of TB, how to deal with them. بقى كم آخر واحدة وزينب هذه زينب لازم نضل نبحث عنها طول اليوم عشان نعطيها جائزتها. طيب هو زي ما قال cumulative. اوكي دكتور نداء ما يصير لازم دكتور مصطفى ياخذ جائزة اليوم. دكتور مصطفى. So the idea here that immunocompromised patient at risk of TB, especially, or at least they are at risk of a progression to TB if they are already in contact with active TB cases. So very important to the infection control and the healthcare provider to know the difference between active TB and latent TB, the spectrum of disease. So, and to differentiate between these tests. So to know when to order the test for latent TB and which test diagnosed active TB. Because TB is a wide spectrum of disease. Now the diagnosis of latent TB means that you are dealing with a patient who had risk of active TB, but he is not infectious. He has the microorganism dormant in his body. His immune system has the ability to control it, but at one day, when he has stress, age, wane of immunity related to treatment, HIV, whatever, there will be a risk of reactivation of this microorganism, and he will be at that time infectious that needed treatment. But in the area that he's at risk with dormant microorganism, you should assess whether he need a preventive therapy, usually with one drug or not. And you should choose those risk factors and when to give them a preventive therapy always. So diagnosis of latent TB can be by two methods: tuberculin skin test or interferon gamma release assay. And the idea of both methods to assess the immune response, your body that exposed to mycobacterium. How was the response? If it was exaggerated response by intradermal testing, this means you are at risk in the future. Other way that is more specific for the intracellular part of the antigen that is related to the tuberculosis, and more specific is the gamma interferon, which is the blood test. Now, the brief, maybe it was mentioned in the lectures that previous guidelines recommend that all new healthcare providers should be screened for latent TB. The new CDC guidelines ask for doing risk assessment in each institution to assess whether you need to do that annually for all of your healthcare provider, or do it just for high-risk people, like travel to endemic area, exposure, history of immunosuppression, and at that time you assess the need for a preventive therapy. So you should have what is the risk assessment of TB in your institution based on the cases, based on the number of negative pressure room that you have, based on your community. Many factors you should address before saying that I should get a guidelines for TB or screening for TB. So latent TB screening test, tuberculin skin test or purified protein derivative, PBD test are the advantage. It's inexpensive, but the problem it can has a cross-reactivity with the BCG vaccine at childhood, despite interpretation of the TST result in adults should it be affected by the BCG vaccine, where we expect the immunity to wean over time with age. So still, it shouldn't have major effect after the vaccination by like 10 years. Another limiting step that you need to wait and ask the patient to come after 48 or even 72 hours later to get the test. Apart from that, it can be positive in some non-tuberculous mycobacterium. This is the assessment for tuberculin test, so you should choose what is the parameters of your the risk factors for your patient before assessment of the duration, of course, not the redness result of the test. The gamma interferon, it's a blood test. It's measure the antigen that is more specific for TB, despite some possibility of false positive in some non-tuberculous mycobacterium, like Mycobacterial canasaceae. No cross-reactivity with BCG vaccine. Sensitivity almost the same. So both tests, if negative, latent TB unlikely in immunocompetent patient. But again, both can be negative and immunosuppressive. So low immunosuppressive patient, you should be very careful when you contact TB patient to say that he is not at risk of reactivation. Especially when you talk about very advanced HIV patient with very low CD4 count, when there is contact with active TB patient, you don't rely on these tests. You just go and give preventive therapy. Again, when you talk about active TB disease differentiated from the latent TB, those gamma interferon and TST used for diagnosis of latent TB before preventive therapy, despite some physicians use it as adjuvant treatment for active TB. But for active TB, you need a clinical and smear microscopy, which has low sensitivity, then molecular tests that show medium sensitivity that detect at least 100 bacilli in the sample, and the most gold standard, but again, it needs time, that is the culture. Thank you. يعطيكم العافية. By this, we finish our symposium and conference. Thank you all for your interaction and for your attendance. And inshallah, see you next year, 2025 in the next Eid, inshallah. يعطيكم العافية.